Good morning, everybody. Thank you to those of us here in the room at Magic Johnson Park. We love this space, as we do St. Anne's. We like both spaces. And to those of you joining virtually, and we are recording today, and you can watch on YouTube, but you can't interact. You can interact virtually on WebEx. And with that, I will turn it over to the chair.
Okay, good morning. It is, I don't know what time it is. It is 9:03 a.m. Thursday morning, July 9th, 2026. And I am calling this meeting to order of the Los Angeles Probation Oversight Commission. I am Dolores Canales, chair of the commission, and we look forward to hearing from our panelists today, commissioners, and the public about many important issues. And thank you all for joining us. We have three main issues today, and we have set timeframes to discuss and act on each topic. So we hopefully can get through everything today with robust discussion. This may mean I may have to ask some panelists and commissioners to limit their discussion in order to get to public comment and be ready to vote or to move on. After we call the roll and approve the minutes, we will start with a panel discussing the benefits and challenges associated with the use of psychotropic medications, including medically assisted treatment for substance use disorders for youth in detention setting. Next, we have an update from the probation's intake and detention control division, followed by a report on probation's visitation policies and procedures. Lastly, we will hear a report from the POC, including the executive director's report and some ad hoc committee reports. Thank you all for joining today. And I would just like to say a special shout out. We have Commissioner Eduardo Mundo, former Commissioner Eduardo Mundo, here joining us today, and I count that as a privilege, and it's great to see you. And with that, I guess we will go ahead. Please help yourself to refreshments over there. It's for everyone. And go ahead and get the meeting started.
Thank you, Chair Canales. Good morning and welcome, everyone. I will start by saying we have really awesome panelists here from probation and from a number of other departments, and thank you. And also, I was asked by Deputy Chief Arcos to express his apologies to the Commission this morning for not being here today. He had a personal emergency, but we have the panelists all set up for the presentations. As always, we encourage real public participation in our meeting. We welcome your comments live or virtually or in writing today. There will be an opportunity for public comment on each agenda item, and then at the end of the meeting for general public comment for items not on the agenda. The way this will work is that Chair Canales will introduce the item. We'll hear a presentation, if any. There are presentations on all of the items today. Then we will take public comment before the Commission takes action on any item. If there are more people who want to participate than we have time for, we may consider shortening the amount of time for public comment or holding additional town halls for specific issues. I can tell you we had such a great experience on our town hall on the Campus Kilpatrick inspection that we have decided we will also be holding a town hall for the Los Padrinos inspection, which is not yet finalized, so we haven't scheduled a date because we need to send it to probation for a review as soon as we're finished with the report, but we will be discussing that in a town hall. As a reminder, please speak directly into the microphones. That goes for panelists and Commissioner Meredith. And I'm just checking to see whether he's listening, and public commenters, so that virtual attendees can hear you clearly. Please stop speaking immediately when your time ends, when you're giving public comment, so I don't have to interrupt you. Please make sure your public comment relates to the subject matter of the item. Please remain respectful of each other and the forum, and any person engaging in conduct disrupting the meeting is subject to being removed. It's easy to participate. If you're here in person, just come to the podium and we'll call you. If you are joining virtually via WebEx or telephone on WebEx, please use the raise your hand function. It's a little hand icon at the bottom of the screen. If you're calling in, you press *3 on your phone to activate the raise hand feature, and we'll call on you with your phone number. You may have to unmute yourself by pushing the microphone button on WebEx or *6 on your phone to accept the unmute request. If you have any technical issues or can't find the little hand icon, please send a chat to the host. Everybody will have 2 minutes today for public comment unless Chair Canales determines otherwise based on our time constraints. If you wish to make your comment in writing, please send us an email to info@poc.lacounty.gov, and Janae will put that in the chat box. Please do not send your public comment in the chat. Only the hosts will see it, and it will not be logged as public comment because it doesn't comport with our Brown Act responsibilities. If anyone in the room needs accommodations today, please see Janae or Sarah in the back of the room. Our meeting, as I said, is being broadcast live and recorded. It's being broadcast on our YouTube channel. It's easy to watch it there, but you can't engage with the POC on YouTube. We encourage you to subscribe, though, so you can watch all of our great videos. Please subscribe to our social media, Facebook, Instagram, Threads, Blue Sky, at LA County POC for lots of information about meetings and recap videos, and please encourage others to attend. Muy buenos días y bienvenidos. Ya hemos iniciado la reunión en vivo y también la conferencia virtual por Webex. Y si le gustaría hacer un comentario público, por favor, tiene que hacer clic en la imagen de la mano y abriremos un micrófono. Tiene que estar participando vía Webex para dar comentario público. Si está viendo por YouTube, no puede participar. Si está escuchando la conferencia por teléfono y quiere hacer una pregunta o un comentario público, presione estrella 3 y le avisaremos cuando sea su turno. Si prefiere hacer sus comentarios en español, le daremos el doble del tiempo y podemos proveer traducción al inglés si lo requiere. I'm going to call the roll now. Please respond when I call your name. Commissioner Brooke Harris, Commissioner Shea Jackson, Commissioner Millie Kakani, Commissioner Don Meredith, Commissioner Sam Prater is absent. Commissioner Tyreek Ship is not here, but we are expecting him, so I will note in the minutes when he arrives. Commissioner Diane Terry and Chair Dolores Canales. Chair Canales, we have a quorum, and I will turn it over to you.
Thank you, Wendy. Let's go ahead and start with agenda item number 2, approval of the June 11th, 2026 minutes. Wendy, do we have any public comment on the minutes?
Anybody want to make public comment on the minutes? We don't have any written public comment on the minutes.
Okay, thank you. So can I have a motion to approve June 11th, 2026 regular meeting minutes? Okay. All right, we have a motion to approve by Commissioner Kakani, a second by Commissioner Terry. Are there any changes to the minutes? Yes.
Thank you.
Thank you so much for that. The world is a better place.
Commissioner Meredith, where is that? Oh, that is in the items not on the agenda, the recognition. Okay, thank you. We will make that change.
Okay, so hearing one change, commissioners, please vote with a voice vote. All in favor? Any abstentions? And hearing none, the motion carries. Okay, Wendy, I'll pass it to you.
Okay, we are, sorry, I'm like, really? What am I talking about here? Okay, I think we're just confirming that we have Stephanie Gluckman online as a panelist, if we can pull her up. And I'd like to invite the panelists on psychotropic medications to join us at the podium, please. Not at the podium, at the table.
Okay, so for agenda item number 3, we will discuss and take possible action on presentations about the uses, risks, and side effects on teens and young adults of psychotropic medications, including medically assisted treatment to treat substance use disorders, especially in detention settings. Probation will share their role in ensuring youth have access to psychiatric medical care through their partners and the impacts they see, positive or negative, of the use of psychotropic medications. Dr. Gongora, please proceed with introducing this item. Thank you.
How's this? Okay. So I just want to thank everybody. I want to thank the commissioners for putting this on the agenda. No?
I think it's not connected to the speakers in the room.
Okay. Okay, is that better? No. Yes. I hear my voice echoing. I know I have a loud voice.
I think you have to bring it closer, maybe.
Just closer? Oh, okay. All right. So I just want to say thank you to our commissioners for putting this agenda item onto the conversation today. And thanks to our DMH and probation panelists for coming in. The discussion about psychiatric services and psychiatric medications made available to young people in detention is an important topic. I think that every time that we enter facilities to do inspections and to do other sorts of visits, we're always hearing from officers and line staff and from DMH partners about the seriousness of psychiatric symptoms that our young people are experiencing during their detentions. Mental health is often at the absolute forefront of conversations and concerns about young people in detention. And psychiatric services are a major, important, critical part of treating young people and helping them to manage the symptoms they experience, right? And so when young people are in detention, we often hear that young people are experiencing symptoms of depression. They're dealing with addictions that they have grappled with on the outside. They're dealing with attention deficit, which can affect their school performance and other ability to manage impulse throughout the day and different behaviors. And they're also dealing with symptoms resulting from trauma. So psychiatric services can be a really critical piece of helping young people to manage those symptoms and helping them to get through their day a little bit easier, and helping them in conjunction with different therapies to move forward and to be able to experience a higher level of well-being. So what I'm hoping that can happen in today's conversation is that there can be a little bit of data that's shared, obviously, about who receives meds, how many young people are receiving meds, what that looks like, but to really have a discussion through the lens of centering young people. What are the effects to young people? What are the trends that psychiatrists are seeing that young people are facing when they're coming into detention? And how do they stabilize? And, for those who are taking medication, like what does the future look like for those young people as, we're, as I think Oversight, always thinking about reentry back into the community. I also think I would be remiss not to mention that the Centers for Disease Control a couple of years ago put out a study that said that children in the United States, aged 5 to 17, I believe was the age range, had a use of medication for mental health at about a rate of 9.3%. And we see rates that are much higher in detention facilities. And so to be able to have this conversation about what young people really need, the challenges they're facing, and how ultimately any services provided are affecting them, including if detention is having any effect on the need for psychiatric medications. So anyway, I just want to thank everyone for being here and would like to hand it over to Dr. Demerla to lead our conversation.
Thank you, Dr. Gongara. First of all, I want to thank good morning to everyone, and I want to thank the commission for having me. And is it better? Oh, great. Thank you so much for having me, having us. I'm joined by Dr. Michael Fitzpatrick, who's my colleague. He's a child analyst and psychiatrist who just took over my previous position as supervising psychiatrist and medical director for juvenile justice. And I'm Hanu Demerla, chief psychiatrist for the forensic psychiatry division of Department of Mental Health. And having said that, I really appreciate your introduction, Dr. Gongara, that we have a very significant topic today, and it's especially significant because there is a lot of suffering that youth go through, and And then, especially in the detention facilities, we do see a lot of diagnoses, and we do see mental health diagnoses, and coupled with substance use disorders. And I think psychotropic medications, and when I say psychotropic medications, that includes medication-assisted treatment as well, which is mainly for substance use disorders, because we in DMH, we do believe in treating both of them. And I think one without the other, you may be, you may not be getting the desired outcomes. So having said that, I must say that psychotropic medications are an important component. I would not say it's the be-all, end-all of everything, but it's definitely a very important, a very significant component of treating a youth and what they're going through, and dealing with them, addressing their needs at that point of their life. Having said that, I think there are two tracks to medication, to treatment. One is definitely the medication wherever it's necessary. And the other part is definitely all the supports that we get from our other partners, from probation, because they have care, custody, and control of the youth in the facilities, but more importantly, also from our DMH colleagues, our clinicians who provide the necessary support, individual therapy, and also this group therapy in our facilities, and including involving their families, and also aftercare. And we do have juvenile justice transitional outpatient treatment services, JJ TOTS, which I've mentioned to this commission previously, that where DMH follows them in the community, into the community. So with respect to medications, I think in some instances, medications are adjunct, as in they are, a part of the entire treatment plan. Like, for example, you mentioned depression earlier, Dr. Kongara. So in that instance, I think medications are important, especially when the diagnoses of depression and anxiety, they are more severe, more significant, then medication needs to be prescribed. But in some instances, medication can also be the mainstay. But even like, for example, in attention deficit, which you mentioned, there's a lot of evidence that to state that in certain disorders like attention deficit hyperactivity disorder, or for example, bipolar mood disorder, or for example, in primary psychotic disorders, which, like for example, schizophrenia, medications can be the mainstay, which is primary treatment. But in certain other conditions, like even with depression and anxiety, and even with trauma, which we should talk about, because we do see a lot of youth with a lot of trauma-related diagnoses in these population. They've seen a lot at a very young age, and there are significant symptoms that they suffer from on a day-to-day basis. So in those instances, medication can be very helpful in just to use the expression leveling the play field, in the sense that if they're having a lot of symptoms, agitation, and if they're feeling very angry, irritable, frustrated, medication prescribed in a thoughtful way, which we will talk about, can actually alleviate some of that suffering. So they're able to, the anxiety and the frustration and the immediate irritability, that gets alleviated to a significant extent, so they can participate in therapy in a meaningful way with the therapist. And fortunately, we have a great DMH team, and all our kids are seen by DMH, and everybody gets screened and evaluated, and they all have an open DMH chart. And absolutely, whenever necessary, we have also a great, robust psychiatric team, I should say, and we do have competent and talented child analysis psychiatrists who are key in us accomplishing this goal of proper and thoughtful and methodical evaluation and treatment of these youth. So there is always a process, and medication is not automatic. and it's done after a proper, thoughtful evaluation. And Dr. Fitzpatrick will be talking about the process a little bit. But one other thing I want to emphasize is that medications are not just, it's not a knee jerk in our juvenile justice settings. It's like something that is done, even if it's a sleep medication, because I know the sleep medication topic keeps coming up. A lot of times, I must say that sleep is an important component, and a lot of these youth have been in the communities, they've dealt with trauma, a lot of trauma, and they do need, it's because it's such an important vital function of the body and the mind. I think it is important for them to have a restful sleep. And we do, even there, we usually try non-medication techniques first. For example, sleep hygiene, relaxation, and those things before a psychiatric referral is done. A psychiatrist sees them, evaluates them, and offers medication. And and the types of medication that we offer too, in generally are, we usually use medications that are safe, considered safe, and that have low addictive potential. And that's just to give you a brief overview. And same thing goes with substance use disorders, which is another very key topic. Even there, we do have psychosocial non-medication approaches. Dr. Fitzpatrick is going to talk about those, address them a little bit. We do have things like motivation interviewing. We do have cognitive behavior therapy, ability to do that. We do have seeking safety and some approaches that are very effective, especially in the context of substance use. But whenever it becomes necessary, whenever it's indicated, we do offer medication-assisted treatment, mainly for opioid use disorder, but MAT is not just for opioid use disorder. We have medication-assisted treatment, for example, for tobacco use disorder, or we could have medication-assisted treatment for cannabis use disorder. I know it's far more documented, and there's a lot of literature more for opioid use, but we do have that ability and that bandwidth to be able to offer that to the youth both in the juvenile halls, our camps, and Dorothy Kirby Center. So I think, but I must say that we see a lot of variegated diagnoses. And you mentioned the number with CDC. Yes, you're absolutely right, Dr. Kongora. The percentage of youth receiving medications is higher in the juvenile justice settings, but also the diagnoses. For example, if mental illness prevalence, last I checked, was if it's around anywhere in the 15 to 20% range, it tends to be upwards of 70%. If you look at national statistics. I mean, I must say, over the years, the total juvenile justice population has decreased, but even with the population that we see in juvenile justice settings, the acuity of the mental health conditions and substance use, which, like I said, we need to address both, that has definitely not decreased. There is a significant amount of that continues to persist. So having said that, I want to pass the microphone to my colleague, Dr. Fitzpatrick, so he can talk a little bit about the process, how we go about in the juvenile justice settings. He'll walk us through from when the youth arrives and take us from there. Thank you, Dr. Fitzpatrick.
Thank you. And to dovetail on what you just said, it's not a knee-jerk reaction to start medications. There's a process that people go through. And that starts from when the youth is first detained. The probation does their own intake screening, which is of interest to us because it includes things like history of mental health treatment, hospitalization, current suicidal ideation, hallucinations, any medications that they might be taking, grief, gender identity, sexual orientation, substance and alcohol use. Right after that, and this is the very beginning, no matter what time they come in to the facility, the nursing does an intake, and that includes all the medications that they might be taking at the time. They also do vitals. They look for symptoms of withdrawal. history of substance use, they contact the parent or legal guardian to get more information and details about any medications that they might be taking. And then if they're on a psychotropic medication, they'll call an on-call psychiatrist, which we provide 24/7, and to continue the medications. It's called continuity of care. And we do a 7-day supply, but we usually have a psychiatrist do an evaluation within the first day or two if they've been taking medications, psychotropic medications in the community. The next that happens in an LP, I think the average is about 24 hours later, but can be up to 2 days later. The mental health clinician does a complete psychosocial assessment, reviews the 2 electronic health records, the one that the DMH uses in general, and our own probation electronic health record, contacts the parent or legal guardian for additional information. They do something called a MASI, which is a screening instrument for things like anger and depression, and they do a scale of that. They do a co-occurring disorders assessment, which is a comprehensive substance use assessment. The parent and caregiver are also given a questionnaire about substance use. And there's also a co-occurring substance use child screening instrument, and they do a Columbia Suicide Severity Rating Scale. A complete physical is also done, which helps inform us as psychiatrists as well, within the first 2 days of being detained. A psychiatrist, they refer to a psychiatrist for several reasons. One, if they have some sort of major mental illness that might be helped with medications, and another is, or if they're experiencing suicidal ideation, history of hospitalizations, or are currently taking medications, or if something comes up during the course of their detainment. They may not have these symptoms when they first came in, but they develop it over time. For our psychiatric assessment, we do a chart review, interview the youth, the parent, legal guardian, get a history of the chief complaint, whatever they came in with or what they were referred for. Any symptoms identifying the assessments, any history of that, history of medications, history of psychiatric hospitalizations and or treatment. Family history of mental health diagnoses or treatment. We take a social history, we do a developmental history going from the pregnancy to developmental milestones, any history of diagnoses of things like autism or intellectual challenges, specific learning disabilities, any history of that. We do a mental status exam and then formulate a diagnosis based on the DSM criteria. We put together a care plan. If a medication is indicated, we use practice parameters established by a committee in Los Angeles, but also used throughout the state. So we follow those guidelines when we prescribe. We get a written consent which goes over the side effects of the medications that we are proposed to be given. We get consent from the parent, legal guardian, and also the youth. If the parent or legal guardian are not available, or if they're under DCFS, we'll go through an application to the courts if we are thinking about starting a medication, and that's reviewed by a child and adolescent psychiatrist and a pharmacist, and recommendations are given to the court of whether or not this is an appropriate medication, matches our parameters, etc. We also schedule a follow-up appointment and do something called a Columbia risk screening at every visit. When medications are given, nurses will ask every time they dispense the medication, and the nurses are the ones that dispense medications in all the halls and camps. They ask about side effects each time. When they visit with us, we also ask about side effects, positive effects, and um, overall well-being during our assessments. One of the requests was that we go over the classes of medications and side effects of particular medications. So let me go over those real quick. It's not going to be very comprehensive just because we don't have that much time, but I'm going to go over a few of the medications and common medications that are prescribed. So the antidepressants, they have names like Prozac, Zoloft, Wellbutrin, Trazodone. There are about 17 total antidepressants that we can choose from. There are older antidepressants that have a lot of side effects, so we steer away from those and go to the more newer antidepressant medications. We choose it depending upon their history of medications, or if there's a family history of using psychotropic medications, we might factor that into our decision making of which medication would be best. The side effects are mostly GI side effects, stomach ache, nausea, diarrhea, those types of things. Weight gain or weight loss, sedation, sometimes decreased libido. Can also be used. These medications are sometimes even used for anxiety disorders like obsessive compulsive disorder, generalized anxiety disorder, and can also be used as an adjunctive treatment for a post-traumatic stress disorder. Some adverse side effects include serotonin syndrome, priapism, and rarely suicidal ideation. For the stimulants, they're for ADHD treatment. Common names are Adderall, Vyvanse, Ritalin. Most common side effects are decreased appetite and difficulty falling asleep. They can also have a side effect of stomach ache or headache. There are other ADHD treatments that are non-stimulants, including Strattera, Clonidine, Tenex, and Wellbutrin. Those can be sedating. Wellbutrin can be activating, increased anxiety and increased energy. It's also used as a MAT for smoking cessation. There are the antipsychotics. Common names are Risperdal, Abilify, Seroquel. They're used in psychosis, but can treat bipolar disorder, aggression, and they're used in Tourette's disorder. Side effects, most common are sedation, headache, stomach ache, weight gain. There's a rare adverse reaction called tardive dyskinesia, which is kind of a movement disorder. If we notice that, we reduce or stop the medication, but there's a certain percentage of folks that the tardive dyskinesia may continue. There's also something called dystonia, which is like a muscle spasm that people can get. That is not a permanent. We also have to monitor for diabetes and increased cholesterol with the antipsychotic medications. There are the mood stabilizers, lithium, Depakote, Lamictal. They're used in bipolar disorder and schizoaffective disorder. The side effects are weight gain, GI side effects, stomach ache, nausea, diarrhea. The adverse effects include lithium toxicity, which includes like an altered mental status, kind of a delirium. We have to monitor for hepatotoxicity, liver problems. So we frequently do blood tests to monitor this. And also look at the blood levels of lithium and they call it valproic acid to see if we were in the therapeutic range. There are antihistamines and hypnotics. These are probably the most common medications that we prescribe, things like Benadryl and melatonin. And those are the same as the over-the-counter Benadryl, melatonin. They're not prescription, but the psychiatrist is the one that manages it. Mostly because there's a lot of mental illnesses that have insomnia as a side effect. We also prescribe a little bit higher than the population that's outside of detention, which makes a lot of sense because folks in detention are under a lot of stress, away from their families, um, worried about the next court date, that sort of thing, and just being detained itself is a stressor. There are the anxiolytics, which means, side effects of those medications are things like dizziness, headache, stomach ache, sometimes dry mouth. There are anxiolytics, which we rarely use just because of the addictive potential of these medications, but they are sometimes indicated for things like alcohol withdrawal, which can be life-threatening. So we have to use these types of medicines for that.
Just to clarify, Dr. Fitzpatrick is talking about the benzodiazepines.
Yes.
Yeah, perfect.
Yeah.
Go ahead. You can.
I'm sorry?
What was?
No. When you said anxiolytics, you were talking
Anxiolytic
about
benzodiazepines, yeah.
Just want to clarify that.
Yeah.
Sorry.
So those are medications like Ativan and Klonopin and Xanax. They're used for anxiety, insomnia, and withdrawal. Their most common side effects are sedation and dizziness. Sometimes the pediatricians will prescribe these medications, the benzodiazepines, if somebody is going through withdrawal. There are other anxiolytics, anti-anxiety medications that are non-benzodiazepines, not addictive, like Buspar and gabapentin. They're usually used for anxiety and aggression. Side effects, again, GI symptoms, stomachache, headache, nausea. And that's it for the...
You might want to mention about MAT medications.
Do you want to go over MATs? Sure. Thank you.
Sure, thank you. So I just want to briefly mention, dovetail on Dr. Fitzpatrick's presentation of various meds, that we also, after a detailed evaluation is done, the MAZI is completed, psychosocial eval, the psychiatrist has seen them, say during the course of their evaluation, the psychiatrist realizes that the youth has been using opioids. And it's been a constant problem. It's been, which includes many of the drugs of abuse, opioids that they abuse, including heroin. These days, fentanyl can be very life-threatening, and we know that about that in the news. I mean, so many overdoses, even in our juvenile justice system, unfortunately. So sometimes it presents as withdrawal because they just come out and then they have withdrawal symptoms, and the nurses actually pick it up, and then pediatricians and psychiatrists could be involved. And we work in a collaborative manner to treat the withdrawal symptoms. But one thing is, we want to be cautious. We are definitely on the side of caution. If the withdrawal symptoms are serious and severe, then we do would prefer to send them to the emergency room so they can be stabilized, and to make sure that, and definitely probation in the facilities, they do have access to Narcan, naloxone for if there's any immediate overdose. I just wanted to make that clear distinction, that we do have to intervene first, and then we do err on the side of caution to make sure that they get sent to the emergency room if we feel that it is the acuity is very high. But if it is on the moderate side, if it's manageable, the withdrawal, then both JCHS and us, DMH, in collaboration, we will treat the withdrawal symptoms. And in many situations, the youth is interested in continuing medication treatment, so they are able to help their addiction issue or their substance use, opioid use disorder in this case. In those instances, our psychiatrists are trained, and they will be, they are able to prescribe medications or the MAT medications, which is the medication-assisted treatment. And the most commonly used one is Suboxone, which is a combination of buprenorphine and naloxone. And it definitely has, it can be life-saving in many instances because it is known as uh, uh, partial agonist in that they don't get the same high that is produced with opioids. So that's a medication that is very commonly used. But there's also longer acting versions of Suboxone, which are also used in our juvenile facilities when it is clinically indicated. And in fact, Dr. Fitzpatrick has used those more recently. And those are known by common names Sublocade or Brixadi. And they're both very effective. The advantage with them is that once you administer those medications, they last in the system for much longer period, several weeks to a month. So I think that can be advantageous, especially. But this is done with definitely with the youth's consent. Now there is a new law in place for MAT. Governor Newsom signed the law, but I think went into effect 2023, if I'm not mistaken, where a youth 16 and above can consent to their MAT, especially if it's Suboxone or buprenorphine containing medication. So that's that's I think could be a potentially a life-saving type of a law, and our psychiatrists are aware of it. We do have regular psychiatry meetings where where we have an avenue to discuss these types of changes or legislative initiatives, so they are educated and informed about these things. And in some instances, youth can also receive MAT with an opioid antagonist, as in when they're very sober, and that's I'm referring to Vivitrol or naltrexone. It's not a partial agonist where the ceiling effect is limited. Here, this is actually an antagonist to, in other words, if these youth are taking the Vivitrol or the naltrexone, then if they were to accidentally abuse opioids, they would run the risk of having withdrawal. So that's another thing that we have done in our facilities, but it does require, I mean, the patient or the youth must be motivated, and we, of course, our psychiatrists are really good about educating the youth about the benefits, risks, side effects, adverse reactions, and that's the reason we are here today to talk about those things. And most definitely, even though there is laws that 16 and above a youth can consent, as much as possible, our psychiatrists try to involve the parents whenever there is a parent available or caregiver, because it definitely leads to better outcomes when the family is involved. There is a caring, a loving one that encourages them to comply with treatment and such. So to that end, we do have various forms of consent, which we get consent in every case. But if parents are available, we can get a witness telephonic consent. And I know Dr. Fitzpatrick has already talked about the court authorization. So in addition to the opioid use disorder, we also have some treatments for cannabis. There are some medications like gabapentin, which we talked about, which can be sedating at times. Or for that matter, we also use N-acetylcysteine is another medication that is gathering some momentum. And then we also have tobacco use disorder medications, whether it's bupropion or the Nicorette and other medications. So I think antidepressants like bupropion can be very useful in tobacco use disorder, which Dr. Fitzpatrick mentioned. So I think overall, compared to where we were, one thing about MAT in youth is I would just want to mention that MAT has been evolving for some reason in the last 7 to 10 years. It was not because these were medications that were off-label because they're mainly used in adults, Suboxone, buprenorphine. But there is a lot of momentum throughout the country because of the advent of opioid use disorder and fentanyl overdoses and all the adverse things that have taken place. There has been a definitive and a thankful momentum that has been provided. And I'm glad in LA we have definitely embraced that momentum to offer MAT whenever it's clinically necessary, whenever it's clinically indicated. and be able to prescribe, have the necessary expertise to prescribe and to continue, and also provide aftercare. To that end, I would be remiss not to mention SAPSI. SAPSI has now a footprint in the juvenile justice settings, and it's been very collaborative, I must say. And our DMH colleagues, they collaborate with SAPSI, and even though we do have an aftercare program, which I mentioned earlier, the
Dr.
juvenile
DeMarla,
justice,
can you just say what SAPSI stands for?
of course, Substance Abuse Prevention and Control. It's a division of DPH, Department of Public Health, and they have been very able and capable partners. So in a way, there's a little bit of redundancy in that we have an aftercare program, which I mentioned earlier, JJ TOTS, Juvenile Justice Transitional Outpatient Treatment Services, and SAPSI also follows them in the community, and also they also have a footprint in the juvenile justice settings. But this redundancy is a good thing. Like I know we talk about having redundant systems in airplanes, just like that here too. I think having something to fall back on, where you have DMH and SAPSI both working hand in hand, so we can prevent as many adverse outcomes as possible. So that would be a few points about MAT and substance use that I make. Go ahead.
Yeah. Now, Nate, the other point is that sure. Yeah, naltrexone is also used for opioid cravings, and that's the main reason why we use it in our halls and camps. Closer, sorry. Okay, got it. Oh, yeah, opioid cravings. Naltrexone helps with opioid cravings. Yeah, and naltrexone. Yeah.
One of the medications that I mentioned earlier.
Yeah. I also want to go over the consent process a little bit. There's the physical consent of when the nurse gives a medication to a youth. They're consenting to take the medication. But before that, we go over the side effects with the youth and the legal guardian or parent. We get either the witness telephonic consent signed, which is we go over the side effects with the youth and the parent or legal guardian, and with a witness that listens in, and they sign as well that we've went over this. There's also the outpatient medication review, which is a list of side effects, and if somebody's 18 or older, they sign that. The parents don't necessarily have to be involved in that particular consent process, but we, of course, encourage the family to be involved. And I also want to go over a little bit about partnering with the DHS pediatricians and nursing. There's actually...
Excuse me,
think
I
that's a
don't mean to
question.
interrupt. We just have one question over here.
One question about consent. What if there is not consent by the parent or guardian? If kid's 15, I don't want my child on medication, what do? Take it to the court?
Yes, so we'd go to the application, psychotropic medication application. If we feel strongly that this person really, like somebody is depressed and suicidal or psychotic, we would go to the psychotropic medication application. And then the courts will decide and either approve or disapprove the medication.
And thank you, Commissioner Harris, because Dr. Gongora, if it's all right with you, there's been a lot of information provided so far. And so I'm wondering if we could just take a moment for the commissioners that might be having some questions before we move on, just because there is so much. One question that I have is, do you have a list that we can have access to of the most commonly used medications? I know you mentioned gabapentin, and some of the side effects of gabapentin is depression, anxiety, suicidal tendencies, and so just if we can get a list, that would be really helpful too, because you've put so many different medications out here. And if I'd like to turn it over to the commissioners for questions, please, if you will.
Sure. If you don't mind, I just want to add to what Dr. Fitzpatrick just mentioned, or if the commissioners want to ask a question first, I'm fine with that too, either way.
Can you hear me? Is this on? Okay. So our parents, is there education around like alternative treatments? Or is that education provided to parents as well as the youth? Do they have time to think about it? And is there even education around things like the side effects or the even stigma? Because there's so much stigma, especially in our communities, around, you know, using medication. So I'm just wondering who's there to kind of help parents and the youth sort through that. These are such big, you know, topics and decisions.
What we do is when we think that a medication might be indicated, we contact the parents not only for consent, but we also give that type of education. And most of these medications don't work as well if we just give the medication. They have to have other types of treatments as well. There's some diagnoses that therapy alone is helpful. So what we do is we give them the information. If they're hesitant or want more information, we provide that, but also give them some time. Say, you know, if you want to get back to me next week and we'll decide whether or not this medication is right for your child. Talk to other people about it, get information on the internet, which is always kind of a little scary. But bring that stuff to me and ask those questions, and then together we'll decide whether or not medication is the right fit, or if you want to try it there. A lot of people try therapy first for things like depression, which can be very effective. Yeah, we do provide that information.
And then I think you said there are certain instances where youth age 16 can consent to things. Is that the same as youth who are not inside facilities? Is it the same age? 16-year-olds can consent to certain treatments without parent consent?
Yeah, it's only the MATs with buprenorphine in it. So that was a statute, a law. So that's the only case, and I think they have that because there were a lot of fentanyl deaths, and a lot of the youth did not want to disclose to their legal guardian or the family that they're suffering with this addiction. So the idea is to prevent these kind of deaths. Counseling in itself it doesn't need permission from parents, but medications do, except for this one buprenorphine.
Commissioner Jackson.
Yes, thank you for your presentation. Are you guys able to provide a specific but anonymous example of a case where you evaluated a youth, the screening tool that was used, as well as how it was determined that MAT would be the most appropriate response to that young person, as well as with emphasis on the ongoing monitoring that results from that process?
There's several screening tools that we use, including the co-occurring disorders assessment, which is the most comprehensive because it gets the entire kind of history of substance use. And we also ask the parents, because they often know, like if somebody had an overdose or wound up in the ER in the past, the parents would know that. And the youth might not necessarily disclose that to us for various reasons. Maybe because they're in the juvenile justice setting, they're afraid they're going to get in trouble for it. So it's not a one-time thing. It has to be an ongoing kind of process. Once you develop a rapport with the youth, they're more likely going to disclose those types of things. We also do a parent caregiver questionnaire, which is kind of a standardized questionnaire, and a co-occurring substance use child screening instrument. So those are the kind of standard screening instruments. But I've always found the most helpful is the co-occurring disorders assessment, because it gives much more detail. What the youth have been using, when did it start, how often they were using it, whereas the screening instruments will just be that. Have you ever used any of these recreational substances or alcohol?
Those are more generalized. Do you have a specific example of a case that you guys followed, like entire life cycle? I'm curious about the use of medication, and do you guys perceive it as a means to an end? Like once a young person is on medication, how are you guys closely monitoring how they're responding to it, how effective it is? And ultimately, I would imagine that if the goal is to create some balance, assuming that there is some imbalance there that the medication is intending to address, at what point do you guys decide that this thing has served its purpose and we can discontinue use of it?
There's certain guidelines that we use, like for antidepressants, it's usually around 9 months of being on an antidepressant, then slowly decreasing and stopping it to see if they still need it. So we do it in kind of a methodical way so that they don't go back into a depression by decreasing it. For substance use disorders, we look at acute, meaning that somebody comes in and that they say going with withdrawals. We might start a buprenorphine product and then wean them off of it. It's a big red flag, though, because we have to look at their history closely to see if they meet criteria for an opioid use disorder, for example. And if they do, then we might continue with maintenance therapy or treatment of a MAT, which is more long-term. We also make sure that once they leave this facility, that they have aftercare, so that they continue, if they wish to continue with the MAT, they'll be able to continue with the MAT. While they're in the facilities, we see them once a week for follow-up. What's working, what's not working. Do we have to adjust the dose, that sort of thing. There's a tenet in child and adolescent psychiatry is that we usually start at a lower dose and kind of work our way up as clinically indicated. We kind of know the dose ranges that work for most people, so that becomes our goal. Did I answer your question?
Somewhat. I mean, for the most part, yes, and I do appreciate that. I'm also curious about the diagnostic patterns. It sounds like in the beginning of the presentation, you guys suggested that the rate is very high. I'm wondering how many youth have pre-existing diagnosis that's prior to incarceration versus those that are diagnosed in custody.
Did you want to?
Sure. I think there is a significantly high rate of diagnoses of all the disorders relative to what it is in the community. Now, is it the chicken or the egg has always been a question, and we look at it in a more comprehensive way, in a detailed way, to see when it started. In many instances, for certain conditions like ADHD, the youth has, in many cases, we get information from the parents and the youth themselves that they've had ADHD from the very beginning. And unfortunately, they did not get the proper treatment for it, or they took medication for a while, then they stopped the medication. And same thing with other behavior disorders, like a conduct disorder, oppositional defiant disorder, that they always had it from their very childhood, as long as their memory goes back. And the parents corroborate that information. With things like depression, that's a great point you made. Sometimes youth can be very dejected when they come into the juvenile justice system, and they may be going through a serious adjustment once they're in the facilities. So I do give credence to what you just said, that but we do have to tease that out, whether it's something that because they got bad news from court, or is it because something's going on in their family life, something's going on the outside, because of which they are going through a severe state of sadness and other depressive symptoms. Because if it's adjustment disorder, which is usually a reaction to a situation, something that's ongoing, then more likely than not, that could subside or get better. It could ameliorate or improve with time, provided they have the necessary support from clinicians. And even if the psychiatrist is not prescribing medications, sometimes the psychiatrist will still see them and to see how things are going. And we do go through the consent process, like I said, talking to the parents and to the other commissioners, query Ms. Terry's query, Commissioner Terry's query. that, we do talk about alternatives with parents, that, if this is something that only started during the detention, that the youth is very, so we do give the benefit of doubt, and we give the parents, some time for them to think about whether they want their child to take medication or not. And we talk to the youth, the child themselves, to see if they want to take medication. So, but the conditions such as ADHD, which is one thing that I mentioned, the other situations are like things like bipolar mood disorder and certain other mood-related and mood and behavior disorders. There's some conditions like disruptive mood dysregulation disorder. It's also called DMDD. It's a relatively newer diagnosis, but I have seen that to be present in the juvenile justice settings. It's also there in the community, but it's a little bit on the higher end, percentage-wise, in the juvenile justice settings. Now, those, the mood disorders and the DMDD, which I mentioned, they tend to get significant benefit along with other modalities of treatment, that is therapy and other things, when they get started on medication as well. So I think it's a careful approach. We do look into how they are doing on the unit, talking to the pediatrician, talking to the therapist who's dealing with them, talking to the caregivers, the parents, whenever they're available. And we base our decision on the basis of many factors. And definitely, like Dr. Fitzpatrick mentioned, past history, like a history of hospitalizations, history of medications. And some of these medications, like he alluded earlier, like antidepressants, if it's a first episode of depression, it's possible to potentially discontinue them, say 9 to 12 months later, if they're doing well. But I think certain conditions like ADHD and bipolar and psychotic disorders like schizophrenia, they tend to persist much longer, sometimes lifelong. So in those instances, it's also our place to educate, inform, and work with them collaboratively with a good rapport with the family and with the youth to educate them that you're going to need this medication long term. So I think it cuts both ways. And we have to be very thoughtful about it. And the same principles we apply when it comes to MAT. Like if it's been a on and off relapsing opioid use disorder. And yes, they went through withdrawal, but during our subsequent evaluations, we found that Suboxone is necessary for maintenance, and the youth is taking it, and there's a possibility that the youth might relapse again, then we would encourage them to go ahead and continue to take Suboxone even after they get released. And it's definitely our role to provide them with the necessary follow-up in the community. Do you want to add?
Thank you. Yes, Commissioner Harris? Oh, go ahead.
I have a follow-up question. This is my last one. And
Okay.
part of my question came from wonder and some worry, to be honest. I think that making assumptions about community conditions in the background of the young people that we serve makes it easier to try to justify the prevalence of certain things, or well, not the prevalence, like the diagnostic patterns, right? But I also worry about maybe the misinterpretation of symptoms. I worry about overdiagnoses. I worry about misdiagnoses, you know what I mean? And the detriment that poses to young people while they're incarcerated. Yes, medication feels important when there are obvious disorders that it can address, but I have personal examples and experiences of kids that just did not need to be on medication, and that prescription exacerbated a condition, right? And we really need to be teaching kids how to cope with things in a sober way versus resorting to medication, especially when once they're released, it's something that they can't really adhere to. So it sort of adds insult to injury when they're sort of exposed to really raw conditions without the proper supports.
Yeah. Yes, Commissioner Harris. Oh, go ahead.
Yeah, you're absolutely right. We tried our best to make the most accurate diagnoses and make a treatment plan based around that. Medications are often a last resort in a lot of these diagnoses, but there are other ones that, like psychosis, for example, that medications can be very helpful.
Mm-hmm.
And that we do need to kind of start early on if we can. Same thing is true with mania. So, but you're right. The other support is needed. And like I said before, sometimes we could use just different types of therapies rather than medications. So we're
Thank you, Commissioner Harris.
It doesn't sound like it.
okay. Yeah.
I got the Commissioner Meredith disease over here. Dr. Gongora said that 9.3% of youth 15 to 17 in the US have some sort of diagnosed mental health condition. Do you keep data? And if so, what is, you just said there was a significantly high rate of diagnosis compared to youth and community. What is the rate of diagnosis of youth with mental health conditions? And to echo Commissioner Jackson's question, what is the percentage, if you keep that data, of youth who come in with an identified mental health diagnosis, and what percentage is identified in the hall through your team? And then secondarily, the same data questions for youth on medication who come in, prescribed medication, whether or not they're taking it, but prescribed, and then what's the rate of prescription in the facilities? If you have, you may not have the data. Do you have access to the data? Could you get it to us later, or could you tell us right now?
We have some data. We keep track of medications, and we do a report. And we at first we do audit all our kids on consents. And I must say, there is a higher rate of diagnoses across the system in our jurisdiction in LA County and nationally as well. It's unfortunately it's 3 to 4 times more. And I would say, in respect to facilities, I think in some of our juvenile justice detention facilities, the rate of medication is higher. For example, at Dorothy Kirby Center, we do have a higher percentage of kids on medications. If you look at Los Padrinos Juvenile Hall, the rate is lower. It's definitely not 9.3. It's more in the 30s with LP, with our recent data. But when you look at Dorothy Kirby Center, where the youth are higher acuity, it does go up to 60% or even higher when it's there. And I think our relative rates with the Campus Vernon Kilpatrick 2, with the girls are being housed currently, is on the higher side. Similarly, SYTF, which is the Secure Youth Treatment Facility in Selmar, the rate is higher. Not as high as Dorothy Kirby, but it could be in the range of 50 to 60%. We also keep track of antipsychotic use, and I know that that was a big point of contention, and there are some places where antipsychotic use in the country, there was concerns that it was reaching 50 to 60%. Now, when I say there's 50 to 60% of youth taking medications, that's not antipsychotics. That's inclusive of all medications. But our antipsychotic use, though, I must say, is much lesser. It's, for example, in some places, it can range anywhere from, I would say, 10 to 20%. In fact, Dr. Fitzpatrick, so recently you did the data too. It's typically around 10 to 20% compared to sometimes the red flags that were raised in the past, that antipsychotic use as well as reaching like 50%. That's not where we are. Fortunately, we are very cautious. Our psychiatrists are, where they are very mindful to make sure that, because the antipsychotics have long-term side effects like weight gain, metabolic syndrome, diabetes. If and when we prescribe those medications, we make sure there's proper labs that are done. For example, glucose, hemoglobin A1C, there's a test for diabetes, a fasting lipid panel, and those are not just in the beginning, but we also, if the youth stays long-term, then we try to monitor them every 3 to 6 months, depending on the clinical need. So all those factors are taken into consideration, and there are times when we collaborate with pediatricians to make sure that other tests, so say for an EKG if it's necessary, or any outside referral for any cardiac concerns or any neurologic issues, say seizures, those are also followed. So I know time is of the essence, but
Thank you very much. Yes, Commissioner Meredith, this is going to be the last question though, because then I also have a question, but Commissioner Jackson and Harris touched on some of the things. Go ahead.
Yeah, this is all Greek to me. So I'm looking for a simple term of roughly in custody, do we have a percentage of how many people have mental health issues and how many of those percentage-wise would be on psychotropic drugs?
Sure.
About 60% of those detained, and it's not only in our facilities but nationwide, have some diagnosable mental illness. And it varies among the facilities, but about 20%, say in Los Padrinos, are taking some medications. Vast majority of those medications are sleep medications, and that's understandable because you come into a facility, you're away from your family, you're not in your own bed. It might not be the most comfortable. You're worried about the next court date.
Or mental depression.
Yeah, yeah. And so there's a higher percentage than, say, the general population and the numbers that you gave at the beginning. So that's the reason why.
Thank you so much for that. And that's, something that raised concern. We did have a presentation by UCLA on the brain activity and being the conditions of confinement, with the gray walls, the cells, lack of sunshine, of course, disconnected from your family, community, human touch, exercise, all of that would, in fact, according to that study, increase environmental depression. And I think that's why there's so many questions as the data on youth that did not have this prior to entering the facility. And one of my questions is, do you have data on youth that are on multiple medications? I mean, you have listed so many medications. So I am requesting a list of all medications prescribed for mental health to the youth, and also data on youth that are on multiple medications. Do you have that?
We do, and we actually gave the last one to Ms. Gluckman. So we're planning on doing that quarterly and presenting it to.
Okay.
I just want to add that Judge Nash, who was officer who retired recently, and actually I'm so glad Ms. Gluckman reignited that effort. That we sent her the most recent stats, and we're going to continue to do that. We keep track of how many youth are on one medication, 2, 3, 4, and so on and so forth.
Yes, and then also if you have data on, you say that, they are of age of consent, or that sometimes the parents do not consent, and then you will file it in court to override the parents. Do you also have data on that, on how many times you've overridden the parents' decisions?
Yeah, this document that we sent has information about that too, as to how many youth had witnessed telephonic consent versus court authorizations.
Age.
And age.
Chair Canales, if you perhaps Ms. Gluckman can address some of those issues. And also, for those of you who don't know, Stephanie works for the Office of Child, Youth, and Family Wellbeing. Did I do that right? Which is the organization that used to be known as Office of Child Protection, OCP, which is in our office, the executive office. So Stephanie and I are colleagues. So I think we can work together to find a way to share that information directly with the commission in a way that is educational and helpful to help you understand it and to address those issues. But I don't want to step on your toes, Sarah, but maybe Stephanie can make some comments.
Is it time?
Yes, it's time.
Can you all hear me? I come to you all from across the world in Botswana right now. So thank you for having me virtually. And thank you so much to my partners at the Probation Oversight Commission and to my partners at DMH. Dr. Demerla and Dr. Fitzpatrick, we have been working together for many years now, and I think have done some good things together. Just to let everyone know, the Office of Child, Youth, and Family Wellbeing, we are a strategic hub for advancing child and family wellbeing policies. We align systems, support upstream prevention, and advance policy and systems change. So essentially, we work across departments on policy and systems change. And so what you will hear from me, because that's my expertise in all of this, though I have a learned expertise in the substance use and psychotropic medication area, really my expertise is how do we change systems based on what we've been observing. So I've been working for over 3.5 years on substance use disorder and youth opioid response work, and on increasing access to MAT for system-involved youth. And my office, as Dr. Demerla mentioned, through Judge Nash, also looked at psychotropic medications for system-involved youth for many, many years. And what's interesting about this is that sort of the goals of these two things have been opposite. We've been trying to increase access to MAT for youth, while we've been really trying to look at and control any overuse of other psychotropic meds. So though there have been improvements throughout the years, what we've been seeing recently and a little bit in the data that I just saw is there's been a little bit less prescription of MAT than we've seen in the past few years. But as Dr. Demerla and Dr. Fitzpatrick said, quite a large number of youth on sleep aids. And though I think this is, medically, clinically necessary, as they opened with, these medications are part of the solution, not the entire solution. And I think with all of this work, in order for us to get to the entire solution, we need cross-departmental work, but most specifically, we need probation as our partners at the table to work on this. An example is Dr. Demerla spoke about sleep hygiene, and whether that's, darkness or quiet or exercise or sunlight, all the things that, and there are many more on that list. I think, DMH, if you're in therapy and you're taught about these things, we need probation as our partners to implement these things. So I think as we look at our successes and our challenges, my main message here today is how do we get probation at the table as much as possible to work with us? And when we look at the work that we've done for the past 3.5 years on medication-assisted treatment for substance use, we have had great accomplishments in increased screenings, increased treatment, updated trainings, updated policy, youth engagement, improved data collection, and one of the biggest achievements we've had probation there only on and off at the table with DMH and DHS and DCFS and a lot of, and DPH, SAPSI, as Dr. Demerla spoke of earlier. We've all been meeting, every 2 weeks for many years, and probation has only been there on and off. When probation has been at the table, we've been able to do great things, such as we were able to get a vending machine placed outside of LP with harm reduction products in it. And it is now the most used vending machine with Narcan and fentanyl strips and all the life-saving things. So we've been able to accomplish some great things. We are still working on updated policies and trainings and many other things that we need probation's participation for. And currently we don't have anyone from probation at the table. So whether it is with respect to Matt or with respect to addressing sleep aids in particular and really trying to focus on the non-medicine, non-medical approach through sleep hygiene or many other issues with psychotropic medications, I think in addition to the questions that we are asking, which are all valuable, it's how do we get probation at the table as our partners to work cross-departmentally on policy and systems change.
Thank you so much for that, Ms. Gluckman. And I am happy to say that there's a familiar face at the end of the table to many of you today who is here on behalf of Probation, Director Catherine Bay, who is here today because of her experience in facilities and currently working at Dorothy Kirby Center, but also deep experience with the LA model, formerly superintendent at Campus Kilpatrick, and the opportunities to understand what it's like to do the day-to-day supervision with youth who are using for the positive and side effects issues, psychotropic medications. And maybe, I don't know, Ms. Bay, whether you're prepared to answer the question about the attendance at the psychotropic medications work group. My thought is maybe not, but if you are, then great. But if there's anything you'd like to share, and also she's here to answer your questions about how all of these issues impact the daily operations for supervision.
Yes, thank you very much for asking probation to join this panel. So our role, I was really happy to hear Dr. Demerla in his very first sentence use the word suffering, because we do see young people in the facilities suffering a lot with their behavior. And our role in probation, obviously we're not the medical side or mental health, although we're trained in some of those things, obviously not to the degree as our partners, is to support young people in their treatment and rehabilitation. And so if they have decided along with their family and medical that they are going to take medication, it is our job to make sure that they receive it when they're supposed to, safely take it. And we also are able to, we've worked on it and we do, I think, a really good job of, we don't need to know the diagnosis of a young person or the medication that they're taking. What we support and help with is, what are the side effects that they may have that we can support them with? Over the years, the medications have, as both doctors said, improved, but I remember a lot of the side effects used to be kids couldn't go in the sun. They had to have more access to water. They might get dizzy. We still are very clear on which medication will make young people more sedated or sleepy, so that we make sure that medication gets to them right before they are going to go down for the night, so that there's no harm that would come to them from being sleepy, right, and still moving around. So most of our collaboration and direct contact is with the nurses that are providing the medication to the young people, and they will let us know if the medication has side effects that we could support the young person with. We also have rapport with our young people, so they will talk about that they're taking medication and we ask them if there's anything we can do to help them. It's our contact with psychiatry directly isn't as much. We usually do it through mental health or JCHS, but I can just recall, it's been many, many years I've worked directly in facilities of the last 9 of 11 years. And the medication, the MAT, that kind of treatment for opioid or young people that are taking, we're taking drugs in the community was a new one for us. So we had to be educated on that in the last few years because those side effects were a little bit different and we needed to have more information on that. But our partnership with nursing, I can just remember even sometimes certain medications are time released, or so young people have to take it multiple times a day. We've worked together on like some medicines you cannot crush, right? Some medicines have to be dispensed that way. So just having all these are just examples of all the conversations that we have without actually having to be a part of knowing exactly what our young people are taking or their diagnosis, and just supporting whatever they need.
Thank you. Dr. Gongora, shall we move on to commissioner questions now? Okay, commissioners. Yes, Commissioner Kakani.
I just want to get back to the sleep aids part, because I think that was really at the root of why I had asked this to be agendized at the last meeting. And I think it's just important to acknowledge that, right, like we are placing young people in a facility that, you know, requires lights to be turned on every 15 minutes, or I'm sorry, maybe the lights are on the whole night. So obviously there are challenges sleeping, as you said, being in a bed that's not your own, being in a space that, you know, you're kind of trapped in until someone decides to open the door for you. All of that, I imagine, is slightly triggering, but I think you might have said that melatonin and Benadryl are used as sleep aids. I guess, I mean, that's always struck me as problematic, that we're using Benadryl to support with sleep. And especially all of the research that's coming out now as it relates to the use of Benadryl, and that it should not be used for a period like longer than 14 days as a sleep aid. And yet I'm hearing of young people who for months on end are taking 75 milligrams of Benadryl at night. That's more than even an appropriate use for an adult. So I'm deeply concerned about that, and our reliance on Benadryl to assist with sleep, and like the extent to which you all are tracking that. And I know you mentioned, Ms. Gluckman, the increase in use, but I'd love to have some more specifics on just the number of young people that are given Benadryl, and whether that is discussed with parents, because it is, as you said, an over-the-counter medication. So are you sharing with parents that we're going to be prescribed, or whatever, giving this young person Benadryl to sleep, and that these are, you know, what studies have reported as kind of concerning side effects, or do you not have to have that conversation because it is not a prescription medication?
No, we do have that conversation, and like you said, that data is kind of new. So we do share with that, and we also have the ability to give it as needed. So it's not every night. So if, say, a youth wants to stay up and read a book, they don't have to take it for that evening. So when the data kind of coalesces, we do talk about the side effects and long-term side effects of you know, extended use of Benadryl and any one of the medications that we use.
Right. If you could just share, if you can share whatever it is, the data around the number of young people who are on Benadryl as a sleep aid, and the length of time that that is being prescribed for, or made available to young people. Yes. And also dosage. Go for it.
Yeah, I just wanted to comment and clarify something. I think that given the current conditions, as you point out, I'm not saying that the sleep aids are not. I'm sympathetic to the concern about Benadryl and the long-term research about it, and you know, all of that. Having said that, what Dr. Jamarla pointed out at the beginning, you know, like without sleep and irritability and combined with the other issues, I'm not saying that the sleep aids aren't needed. And I think we need to focus both on the amount of sleep aids and which type we're using, but also the sleep hygiene. Like, what else are we doing? How are we creating conditions within probation, by probation, care first, where we're setting up conditions where it is more likely that the youth will be able to sleep, will be able to implement. Maybe even they get involved in youth engagement and, you know, coming up with programs about what does sleep hygiene look like and how can it be implemented? How can it, you know, I think there's a lot of work that can be done. And if I am correct, and maybe Dr. DeMarlo, you can speak to this, I know from 2016 to 2020, there was a physician at DMH who took it on as a project to work on sleep hygiene in the camps and halls and was making some improvements. And then when COVID hit, that all kind of fell apart. So there is some history with this. And I think it would be great if we could partner with probation to work on that again.
I agree, and I appreciate that. But to your point, I've always wondered why we don't give kids eye masks at night, right? I mean, if you're going to have the light on all night, how hard would it be to give a young person a mask? Even a weighted mask probably makes it easier to sleep. But instead, we're relying on Benadryl as if it's like a necessary evil. And so I just, you know, ask all of us to kind of challenge that thinking. And to your point, Ms. Gluckman, like, how is it that we can better care for our young folks without having to rely on things like Benadryl? But I think that data would also be super helpful, because I know it's not oftentimes considered a psychotropic medication. But yeah, my other question was related to when a young person, you know, a psychiatrist prescribes a medication, young person says, no, thanks. Family says, no, thanks. And then you all go to court and then get the whatever, the judicial order. And if the young person then refuses to take that medication, is that then reported to the court as like a negative behavior or a, you know, I just worry about that kind of being used against a young person, like their refusal to take the meds or their, yeah, you know, they don't like the way it makes them feel, so they stop taking it. So just curious how like use of medication or inconsistent use of medication is reported to the court.
So that's a great question, Ms. Commissioner Kakani. So I think consent is always a combination of the consent given by the parent and assent on the part of the youth. I mean, it's a combination of both. Now, we cannot force a youth to take medication. Having said that, like Dr. Fitzpatrick described in his the anecdote that he detailed, where or not, it's not an anecdote. He was just explaining how we go about things in terms of when there is a youth whose parents will refuse. We don't always, petition to the court right away if a parent or caregiver refuse. It all depends on a set of conditions. Depends on the diagnosis. Depends on the acuity. This is especially becomes necessary when the youth is getting hospitalized, being sent to the ER, and there's so much of self-injurious behavior taking place, and they're constantly on enhanced level of supervision, and there's a history of them being diagnosed with pretty significant diagnoses. And there's a lot of factors. Having taken that, and in that instance, when sometimes youth is actively psychotic or having aggressive anger outbursts, it's pretty significant, then we will petition the court, especially when the parent says no. But having said that, the scenario that you described, because the family said no and the youth also starts to refuse, well, that's unfortunately a complicated situation that is not uncommon, and it does happen. And in those instances, I think the psychiatrist tries to engage the youth along with the mental health team to explain as to what the risks and the benefits and the side effects, as to why is it that we are wanting them to take medication. Just because we get a court consent doesn't mean that it's an involuntary medication order. We cannot force them by any means. That's totally different. Court is only consenting as parents patriae. In that instance, they're acting like the parent to provide consent. But sometimes we may, if the youth is deteriorating, we may have to look into higher level of care, like hospitalization, and we call it level 4 in our facilities. I mean, they get hospitalized, and we may have to advocate for them, not just go to the psychiatric emergency room, but actually to find them an adolescent inpatient unit. And Unfortunately, there is a paucity of beds for children and adolescents in general, and much more so with respect to juvenile justice youth. I mean, not many hospitals take our youth. But every once in a while, with all the efforts, concerted efforts that we make, we're able to find a bed. And in a few cases, we even pursue something like LPS conservatorship if the situation on an outpatient basis, obviously. That's not like in adults where it's very common. It happens, though. And once they go to the hospital, though, there have been instances where they do work with the doctors there in the inpatient unit, and they get placed on a medication that they're willing to take. There have been also a few examples of youth coming back on long-acting injectables, LAIs, so they can continue to take the medication once a month with the proper consent, obviously. So that would be what you described is a very complicated scenario that we have to address clinically on a case-by-case basis.
Right. And I feel like the scenario that you're describing is like the most serious, right? Where there's like the young person is deteriorating and requires significant like medical attention and supervision. But I wonder if you're aware of like all of the other young people who are in the less serious situation, but who simply refuse to take their medications because they don't like to. And I'm not sure that you all understand the implication of like what it means for a young person to refuse to take their medication in court. And I think that's like the disconnect that I'm seeing and worried about in terms of how it affects young people when it's reported to the court. And it's, it might not be the situation where the young person is deteriorating.
Yeah, I think it should not be a punitive. I agree with you. It should not be a punitive situation, and it's clinical. It's purely taking us recommending medication, prescribing medication, and the youth agreeing to take medication is strictly a clinical process. And when the law affords them the ability to assent or to agree to take medication, notwithstanding the parents' consent, it is total. There cannot be a punitive attachment to it. And I absolutely, I echo your sentiment.
Yes, thank you so much for that answer. I still didn't understand your answer though. So it is clinical, but once the judge has said, okay, I'm overriding the parent, the youth, everybody's decision, this youth must mandatorily take medication. Should the youth, where it's not an escalated situation, should the youth say, no, I'm not wanting that medication, does clinical write a report to the judge that has ordered forced medication?
Unless we're specifically asked, we don't. I mean, we don't just automatically generate a report to the court saying youth is taking or not taking medication.
Yes, Dr. Gangora?
I actually think it's a question for probation. Does that get reported in any way in any of the reports that go to the court?
Thank you. Yeah, not to Ms. Kakani's question, no. So unless it is the extreme situation that I have to say I'm sitting here thinking about in the last 10 years, I cannot recall a situation. Doesn't mean that it didn't happen, but in my experience, it did not happen. Unless there is a direct order from the court requesting information about treatment and medication, which we would then ask medical to provide. We don't report it as, I think the concern is a violation. We do not do that in probation.
Thank you so much. And we obviously did not give this agenda item enough time because we are over, but there's so much to it. And there is not just one right answer because it's by a case by case factor, which I totally understand, but I think I have like 10 more questions now with all the information that's been provided. So one last question from Commissioner Terry, and then we are going to move on to public.
Does the medical information travel with the young person if they go to county jail or to another placement or even home? Is there a transition plan? Are those records, it follows them?
Yeah, it definitely follows them. They get a discharge summary. We provide a month's worth of medication to whatever pharmacy they want us to send it to, or they can have a paper prescription that's included in their mental health packet. So probation does a packet, and we do a packet too for mental health, and so does medical. So all that information and prescriptions are sent with them.
Okay, and then only because it's come up twice now that Ms. Gluckman raised about partnership, I'm just wondering, what would a stronger partnership look like? Are there not regular meetings happening? It sounds like you had mentioned like not having a seat at the table, so what would that actually look like beyond the sleep examples you gave, which were really helpful?
Hi, thank you. There are regular meetings. I think, so I don't know if they're having psychotropic med regular meetings, but we still are having the substance use meetings, which, as I said, we still fail to have appropriate policy and training and a whole bunch of things that are still due. That we still want to work with probation, and probation isn't at those meetings every couple of weeks. And then we also have a once a month meeting as well, which again, I just want to point out that Dr. Demurla, Dr. Fitzpatrick are regularly at those meetings, but we really need jointly to have someone from probation at that table.
Thank you so much. And Wendy, do we have public or written comment on this item?
Thank you. Janae, do we have already submitted written public comment on this item? I don't think so. If you'd like to give public comment, please approach the podium. As you're doing that, I just want to say thank you very much to the panelists and the commissioners today. This was a really robust presentation and I learned a lot. Thank you. And so we'll start. Do we have the clock? I can't see it. It's ready to go. Okay, you've got 2 minutes. Welcome. Thank you for being here today.
Thank you. My name is Rochelle Amesco. I'm the director of the Juvenile Justice Clinic at Loyola Law School. I want to give you a few stats for some of the young people we represent. A 15-year-old male weighing 128 pounds is prescribed 150 milligrams for 6 months of Benadryl for sleep. A 14-year-old male weighing 124 pounds is prescribed 100 milligrams daily for 6 months for sleep. For reference, a single adult dose of 1 Benadryl tablet is 25 milligrams. And most adults who've taken a single dose of Benadryl know how drowsy a single dose can make a fully grown adult. At least I do. There is a concern about young detained people not being able to sleep. Indeed, I am sure the number of young people detained actually wetting their beds at night due to the trauma of removal from their communities is even higher than we know. In addition to the trauma of removal, sleep disturbance is a common symptom of ADHD, ADD, and other neurodivergent issues and other mental health issues generally, as I'm sure you are all aware. I was asked, what I have seen in court and through my own interactions with the young people that we represent is that Benadryl has an impact on the daily functioning of young people, which can at times manifest as negative write-ups and behavioral issues. And for the record here, every single denial of a young person who chooses to not take their medication is provided to the court in a report, and we are often litigating those issues. I have asked on numerous occasions in court, and the court has ordered a report from DMH on the long-term effects of diphenhydramine on young people with neurodivergence, and long-term effects such as dementia and long-term reliance on sedatives to treat underlying issues. When we sedate our young people on long-term use of extremely high non-FDA approved lengths and doses, we impact a young person's reliance on sedatives. This is a huge issue, and I am grateful to the commissioners for bringing this up, and I hope to receive a report soon based on the court's orders. Thank you.
Thank you very much.
Hi, Kevin. Good morning.
Hey, good morning. Thank you, Director. My name is Kevin, aka 5150. So I remember when President Mondo was in charge, he always making sure that we have equal amount of time across all items. But today you take 2 hours in one item, so I don't know how are we going to continue the systemic racism against all other items. So I'm a little bit concerned about that. Second is that I think Commissioner Jackson asked a pretty good question that about misinterpretation of symptoms, about misdiagnosed of certain individuals. Yes, because I remember that some of my professors reported me that they told me that I just cannot put my hands down in the class. And they report me to the dean, and then the dean said, well, there's nothing wrong, go back. So yes, I'm definitely a little bit concerned about that, because There are some people are saying that, hey, I need on mental health, I need on drugs, I need on this, I need on that. So I'm glad that I didn't go to the probation department. I went directly to a state penitentiary. Otherwise, I think end up in the probation, you guys gonna drug me. Now, continue about the sleeping aid issues, about the sleeping aid issue from the Commissioner Kakani. Did you guys went to the Chinese airport or maybe the Japanese airport? They have something called a sleeping pod. So you can Google it yourself, go to the airport, see it yourself. So sound isolation, light isolation, quiet temperature control. So if you want a best sleep of your life, a typical coffee shop of China, Japan, they have those special sleeping pod. So maybe that is something that you can look into, but I don't know. But yes, I really do have a million questions about this, because I just hopefully people don't get drugged when they don't want to, because I was trying to, some people trying to drug me, but I say no to my parents.
Thank you, Kevin. Yes, Mr. Bell.
A lot of information. So I hope I ain't asking questions that already been answered. One, with the kids that come inside already taking medication, are you guys in contact with their medical record or doctor on the outs to make sure they're actually taking that medication and that they're taking the right doses? Or you guys just ask the kid and parent and go off their word? Because that's not always the best thing. Two, the kids that are inside and they haven't been taking the medication and they start taking it while they're inside the camp. That is my concern, because I've actually seen kids talk to other kids to tell them what to say in order to get this medication. Or I've seen kids who I just want to go to sleep faster. They don't really need it. They just want to sleep faster. So they go out and try to get prescribed Benadryl, which does have side effects. I think dementia or something I heard about in the long term. But they don't actually need it. They just want it. So how do you guys look at a kid that's already inside and say yes? Or is there a time where you guys could say no? Based off everything they tell you, you determine, no, you're not getting the medication. Or do they all just get it, start taking it, and then you see what happens after they take it? Because, a lot of these kids as well, they get talked into getting these medications so that they could share it with other kids. Now those medications end up in a bottle full of water mixed up, and now the whole dorm is taking the medication. So how do you guys go about saying no to a kid when they actually try to get the medication as well? Thank you.
Thank you, Mr. Bell. Dr. Demrella, can you answer if you were able to, because I know Commissioner Shipp had that question also, if you talked to the doctor prior?
I'll also have Dr. Fitzpatrick join me because he actively sees patients as well. Yes, we do verify, we corroborate the information. Actually, our nurses, the first task at hand when a youth walks into the juvenile hall is to find out if they're taking psychotropic medications. It's one of their items that they have to go through. And once they get some information, they immediately call the parents and try to get as much info as possible about the medication, the dose, the frequency, compliance, and other things. Only upon then will they call the on-call psychiatrist, and the on-call psychiatrist also looks into the appropriateness and of the medication, the dosage, and other aspects, and then they usually continue it if it's deemed that the youth has been taking medication for 7 days, but only to be followed by psychiatric evaluation and follow-up within a day or two of in our facilities. So Dr. Fitzpatrick is also one of our on-call psychiatrists, so I just wanted him to chime in too on this.
Oh, yeah, absolutely. And I guess the crux of the question is collateral information. How do we obtain collateral information? Do we respond just to what the youth tells us, or so we use parents? We do get a release of information from the prescribing physician, and we have probation to do sleep logs. what time they've fallen asleep, are they staying asleep? Because there's about 10-minute checks that they usually do every night. And just to jot down, okay, they seem to be sleeping or not sleeping. So again, collateral information. Parents, we would ask questions like, did they have any sleep problems when they were at home? And when they did, if they did, what medications would they take, if any? We do have a protocol for between 2 and 4 weeks of sleep hygiene before even referring to a psychiatrist to consider any medication.
Thank you very much. And we are over time by a lot. And, you know, sometimes though, the interest of the people is greater than the interest of the time.
We have one online public comment. Sorry, it just popped up.
Okay,
Can we
and
take
we
that
just
really
got
quick?
an online, and then I
Yes.
will close and ask the commissioners if they have any closing questions.
Okay,
before-
so we'll take one online public commenter, Derek Blassingame. We'll unmute you. You may need to unmute yourself as well. Derek, can you hear me? You're unmuted on our side. Okay, well, I welcome you to try to work on the audio issues and comment at a later time during the meeting, but with that, we can move on.
Okay, thank you. Commissioners, do you have any closing questions? Yes, Commissioner Ship.
Yeah, in brief, and I've been thinking about this, like in brief, can you talk about that aftercare piece, right? Because for a young person coming in and out, they may not always have access to those drugs. But for somebody who's staying a lot longer, they may. And or is that something that we are prescribing them the drugs and giving them longer dosages? Are we paying for that? Is that the county paying for it? Or just how does it work in general? Like you mentioned aftercare, but I would love for you to expand on it a bit.
I'll start. So we established the J.J. Tots program, DMH did, Juvenile Justice, Transitional Outpatient Treatment Services. And Dr. Streich, who's sitting in the audience, and I had initiated that program. And we also have a strong presence of psychiatrists in that team. So even before the youth gets released, while they are still in the facilities, we have a J.J. Tots referral for every youth that is placed. Initially, this was only a pilot for camps, but we have expanded it to all the youth in the county. And so we did it with existing resources. So our own psychiatrists in the facilities go to these various area probation offices typically to see these youth. And so we have them in different areas throughout the county. We also do some hybrid whenever necessary. Especially during the pandemic, we did have to do a lot of virtual. But lately, there's in-person on-site sites that are open for our J.J. Tots, psychiatrists, and clinicians. So it's once again, our J.J. Tots program is Medi-Cal certified, and so the good news is that our psychiatrists in the J.J. Tots Transitional Outpatient Treatment Services, their main goal is to make sure that the medication is continued by the psychiatrist because we don't want them to slip through the cracks. And secondly, provide them with solidified linkages in the community to other DMH directly operated as well as contracted clinics. And also assist them with various other situations. Say, for example, if their Medi-Cal is not active, or how can they reestablish that? If they're having any type of problem, then it's not just a psychiatrist, but they work like a team with other clinicians to try and problem solve with other issues that they may be having. We also are able to continue MAT medications in that on that platform, the J.J. Tots platform. Yeah.
And to also answer your question, there are sometimes when Medi-Cal is suspended while somebody is detained, and DMH provides an insurance for that. It's called Magellan, and it'll cover the medications until they're linked to somebody more permanent in the community.
Commissioner Ship, I actually think your question might be worthy of a full presentation at some point in terms of not just aftercare for young people leaving detention, but also youth on probation in the field who never come into detention and adults on field probation and their access to DMH services and other services for mental health issues. I think there's a lot of work that's been happening and is projected to be happening that might be a useful presentation in the future.
Thank you. Commissioners, any more questions before we close? With that, panelists, thank you very, very much. You came with so much information, and thank you for your time. And we look forward to talking again soon.
Thank you, Probation Commission, for having us. Really appreciate it.
Thank you. And with that, we're going to take, I'd like to make a motion for a 10-minute break. Oh, okay. We're going to take a motion, and we're going to take a 10-minute break. We will come back at 11:07. Thank you so much.
Millie's right there.
Okay, thank you very much. It is now 11:09, and we will move on to agenda item number 4. So that is to discuss and take possible action on a report from the Los Angeles County Probation Department regarding continued improvements and collaborations related to intake decisions and detention recommendations, including a report on progress in sharing Los Angeles Detention Center screening, which is also referred to as the LADS, scores with the juvenile court and court parties. Discussions will include progress the department has made with improving the quality of intake reports, recent reductions in population, and progress on implementing the recommendations made by the Office of the Inspector General in assessment of probation's detention reports. The probation department was asked to provide updated monthly intake data, which they have. Attached to the agenda are reference documents on this topic from previous POC meetings. And I would like to welcome Director Maricon.
Director Cesar Mallorquin.
Mallorquin. I understand you have some positive updates to share with us today about your work, and I'm looking forward to hearing them.
Thank you. I also brought Tom Schofield, who's part of our IT team at Downey headquarters. He's been very instrumental in helping us with the data collection. All right. Well, first off, I want to thank everybody for inviting me. Thank you, commissioners, for having me on board. I'm here to provide an update on what's been going on with intake and detention control. There was data that was provided to the POC, that has been provided to the POC since September. And I will talk a little bit about that data and also some of the questions and address some of the questions that you have brought forth in the past. First I want to say is that prior to September 2025, IDC was collecting some data, but we've actually enhanced our process in collecting internal data. We've been able to provide the POC with steady information and statistics to show what the percentage of youth that are being detained, the percentage of youth that are being diverted away from juvenile hall. But part of it was we had different areas that we were addressing. So the intake and detention control stats was one of them. One of the main things that we did work on in January, that we worked on late last year and implemented in January, was a revised modification of the detention criteria. Now, this was under the recommendation of one of the stakeholders of the Department of Justice, and as well as under the leadership of Director Arcos. The revised detention criteria now separates the required detention at intake based on statute, court order, and also departmental policy. The previous detention criteria.
Can I ask you to just speak like a little closer to the mic?
Oh, sorry about that. My apologies. Yeah. So one of the great things that we've done in IDC since last year's we've generated stats that we've been able to provide to the Probation Oversight Commission, and that's one of the good things that you guys have been able to do to analyze and look at the data and understand what's going on in IDC. One of the other things I wanted to bring up is that in January 2026, we modified the detention criteria because that was one of the questions that a lot of the stakeholders had, and also law enforcement agency, as well as the POC, like who's being detained, who's not being detained. We did have a detention criteria that was presented to the POC, I believe, back in 2024. But there was some issues with that detention criteria. So one of the things that we did, we revised it in January, and it's been presented to the POC as well as the stakeholders and the judges and also law enforcement. So one of the differences is under the recommendation of one of the stakeholders, Department of Justice, they were basically saying, well, how are we breaking down these mandated detentions? So we basically separated the mandated detentions into 3 areas, which is statute, court order, and departmental policy. The previous detention criteria did not indicate that. So it was important to know for the stakeholders to understand why is IDC detaining certain youth at intake. So under the revised detention criteria, the list of charges are actually listed in the document, which gives the probation officers, the IDC probation officers, a clear guidance on who needs to be detained and who shouldn't. So in that, also in that detention criteria, there's a fourth category which identifies cases where where detention may be required under unique circumstances. So one of the differences now with this fourth category is that these charges that fall under this criteria require an override. I do want to mention that in the prior detention criteria, that override was not required. So I do want to say that this is something good, because an override is basically an assessment from the probation supervisor to ensure that we are not just detaining any youth. I did mention in the past meetings that there were charges listed under family domestic violence. There was charges listed under evading, also resisting. Under the prior criteria, those were basically standardized detentions. But after reviewing the policy, after talking to our executive team, basically we went back to the basics. Those type of detentions do require an override, which is an extra layer that prevents unnecessary detentions. So that's a good thing. I just want to say that. All right. I do want to point out that under certain charges like domestic violence, we've actually added an extra layer of questions that our IDC officers are asking the law enforcement agencies when a youth gets detained. So we don't want to detain youth, and we try to divert youth as much as possible. And some of those questions, is there, I'm going to basically explain the questions. Is there a history of violence? Was there any physical contact? Was a weapon used? Does the youth pose an imminent threat to the victim in the household? And are there any relatives willing to care for the youth until the youth goes to court? And last but not least, has DCFS been involved or contacted to see if there's any other alternatives to detain the youth? So again, these additional questions that our IDC officers are assessing with the law enforcement agencies during the phone assessment is very crucial to again minimize any unnecessary detentions. Obviously, if all resources are depleted, there's a case where there might be an imminent threat to the victim in the home, we have no choice but to detain the youth. I do want to say that based on the data that we've been providing, roughly 5%, 4 to 5% of the detentions are categorized as overrides, which is a good thing. 95% are listed under our mandated detentions. And again, IDC is doing as much as possible to try to minimize detention. So we are pretty much on the right track and trying to be in alignment with the population reduction. All right. And I do, last but not least, regarding the detention criteria, it has been vetted through our county council and it also has been submitted to the POC, which is part of the attachments that are listed here. There were the questions regarding the data, and this had to do with the detention recommendation and the court outcome. So prior to September 2025, IDC did not track the court outcomes. The idea of tracking the court outcomes was to gain an understanding of how the criminal charges and the underlying facts that drive the court decision to detain or release the youth at the detention hearing. So in other words, are the judges or the court judicial officers detaining based on egregious or certain charges? What we found that's not the case. There's a variety of charges that are resulting in detention at the detention hearing. And a good example would be you might have 2 youth who have the same risk score with a robbery charge. One judicial officer might release the youth at the detention hearing, whereas another judicial officer will detain the youth at the detention hearing. So we've been tracking that data. But based on numerous cases, the judicial officers are hearing complex cases, and due to these unique cases, they're being presented with underlying factors at the court hearing that will aggravate the case and result in the youth being detained. I did have a conversation with the presiding judge, Judge Espinosa, and he basically confirmed that they are hearing complex and unique cases where additional underlying factors are presented to the court. So it's incumbent upon them, and they're tasked to decide whether detention is a matter of immediate and urgent necessity for the protection of the minor, or tasked to decide whether detention is immediate and necessary to the minor, or reasonably a necessity for the protection of a person or property of another. And that's pretty much listed in the Welfare and Institution Code 628. So they're hearing complex cases. They have to hear information that's being presented at the court. So they're utilizing the detention report plus the information that's being presented to make an assessment and decision whether to detain the youth. So a lot of this information is basically taken out of the probation department's hands. Based on the data that has been presented to the POC and that we've been collecting from January through April 2026, the data shows that the court agrees with the probation's recommendation to detain at the detention hearing at an average rate of 76%. However, 22% of the time, the court outcome is more lenient, where the court disagrees with our probation reports and release the youth home with or without CDP. And the remaining 2% are basically like TA rejects, or the youth is actually released prior to court for other reasons. Conversely, from January through April 2026, the data also shows that the court agrees with the probation's recommendation to release with or without CDP at a rate of 61% of the time. However, 35% of the time, the court outcome has a more strict detention decision where the court disagrees and detains the youth. So that kind of goes in alignment with the discussion with the presiding judge on the complexities of some of these cases and the reason why they decide to detain the youth. Again, that's out of the control of our department. Therefore, how do we work with this? So as an IDC director, and the goal for IDC is basically to review and assess cases to ensure that the IDC officers are following policy and remain with the recommendation parameters. I recently presented to the judicial officers, the public defenders, the DA's office, and also the court officers who are pretty much the liaisons for the probation department in the courtroom. And our goal is basically to provide a better quality report. We want to basically ensure that the reports are objective. However, within the parameters, that there is some subjectivity to ensure that we are actually making the appropriate recommendation based on the risk score and also the aggravating and mitigating factors. So ultimately, it's our job to provide an independent recommendation based on law, policy, and the information that we have at the time of the detention hearing. I do want to say that when a youth comes in, we are limited with time. We have a 24-hour window to complete a report. And unfortunately, we're not able to get an extensive social study of the youth within those 24 hours. So we try to make a most accurate accurate recommendation based on the facts and the information that we're receiving at the time that we're creating the detention report. I do want to say that one of the other good things that we've done based on the recommendation with the Office of Inspector General. So back in December, we were presented with an analysis of the court reports and also some recommendations. I do want to thank Mr. Lacey and some of the other team members from the Office of Inspector General who did work with us to kind of review their assessment and review some of the reports that were presented. And yes, there was room for improvement, and we've been pushing forward with that. One of the recommendations was to basically include the LAD score in the court reports. So I do want to say that we successfully accomplished this task. again, I met with the judges, I met with the district attorneys and the public defender's office and provided some historical information on the LADS, training on how the LADS score is assessed and generated. And we pretty much went live with the LADS score on the detention reports as of June 22nd, 2026. So we did have an objective date of June 30th, so we were ahead of schedule. So that is a good thing. Again, having the score of LADS inside the detention report obviously opens up a slew of questions between the public defender's office and DA's office. We've been working with my team at IDC to ensure that they're doing a quality and ensuring that the LAD score is scored accurately and assessed appropriately. So a lot of the things that, unfortunately, like the LADS is not a perfect risk assessment, but again, we are trying to make the most accurate assessment. So I do want to say this, that the detention decision is not only based solely on the risk score. There are aggravating factors that may require a recommendation to detain. So one of the questions that's been brought up is, well, what does the risk assessment score mean? So we've established a criteria, with 0 to 3 being a low risk, 4 to 7 being medium, and then 8 and above would be a high risk. So the goal is basically, ideally, somebody with a low risk, you would ideally recommend release, right? But that might not always be the case, because there are some aggravating factors that will require us to continue detention based on the charges. For example, we might have a youth that's detained on a murder charge. Although the youth might score low on LADS, there is, there's additional investigations that are being done by the law enforcement agencies that are happening during the trial. And so at that point, we have to make a recommendation to continue detention. However, to ensure the quality of our reports, our officers are being trained and instructed to justify and also explain that in the court reports. So that's part of our quality, and also, one of the things that we're doing in IDC. I did mention that we did train the judicial officers and the other stakeholders. So one of the questions that you guys asked was, what was part of the curriculum? So part of the curriculum was, we talked a little bit about the history and the implementation of the LADS, how it was validated twice, how the actual risk assessment is facilitated and the questions that are asked in that in the score. How the LADS works with mandated detentions. We did discuss the mandated detentions. I also discussed the workflow, IDC workflow, which is, I believe it was presented to the POC, but it's also been presented to the other stakeholders. And it basically explains what IDC does and how, we are limited with the mandated detentions, how we do have to detain those youth. And also, the court recommendations, what is being recommended based on the LADS plus the mitigating factors. And also, it also showed a demonstration of where the LADS score is being demonstrated on the report. But to add to that, based on the last validation back in 2022, there was a need to come up with a new revised risk assessment. So I know that was another question that the POC had. That there was, talk about a new revised score. I do want to say that there's, I brought Tom here because he's been leading the team that's been doing the revised risk assessment. He's been doing an excellent job and leading multiple teams to basically come up with the new risk assessment that's actually in the validation stage right now. And it won't be implemented till most likely next year. So of course, in order for something to be successful, you have to test it and see if it's actually in alignment with what the goals were. And let's see here. I think that's pretty much it. I guess we can talk a little bit about, I did want to talk a little bit about the data, because there was a lot of questions regarding the overrides in the April meeting. I provided the POC some documentation, including the policy regarding the overrides. I do want to say this, that an override is not a bad thing. An override can be a positive thing because it does provide an extra layer of discussion, and actually it requires a supervisor to actually deny or approve an actual intake. What was happening in the past, there were certain charges that did not require an override. So one of the good things that we did recently is basically, we are requiring an override. And so we are now documenting, we have been documenting those overrides, and they are documented in the data that we are providing to the POC on a monthly basis. So one of the things that I wanted to point out in the data spreadsheet that I see here from throughout the years, the last 2 months, we actually combined some of the overrides. So like the evading charges that were actually listed as a sole, criteria, category, we had evading, resisting, and family domestic violence. Those are actually overrides. And on our data, we've actually been listing that as an override. So when you see an increase in the overrides for the month of March and April, that's basically that we combined some of those charges. And what I'm saying there is that those cases are not just solely being detained just because the officer makes that decision. That means that the supervisor did have a discussion with the probation officer to make sure that they approve that detention. Again, that's an extra layer, and I just wanted to point that out. I think I addressed, so the quality assurance, I think that was another question that came up with the POC, as well as with the recommendation from the Office of Inspector General. And our IDC operation, basically, we are doing an internal quality assurance, reviewing every case as far as basically the first line of defense is a supervisor who actually reviews the reports, and they're actually, identifying any discrepancies as far as whether the report is accurate, whether it's factual, whether it falls, whether it's following the policy, and if it's in alignment with the law. So that is the first line of defense. What we've done is created like a checklist for each, for the supervisor to, when they're reviewing the report, checking to see if the recommendation is done accurately. They're checking to see if there's any discrepancies as far as the parent statement, making sure everything's completed thoroughly. And ultimately, as the director for IDC, I'm the quality assurance overseer. So one of our goals that I've always talked about is that we want to ensure that we're at least grabbing a snapshot of the reports that are being submitted, and also reviewing those reports and making sure that those quality check sheets are completed thoroughly, and making sure that the supervisors are doing some type of self-accountability, and also training the officers if there's any discrepancies, or to see if there's any patterns of errors that are being made. So again, I think that's a positive thing that we've done as far as establish the quality assurance. And I think that's pretty much all we have for an update. So if you guys have any questions.
Yes, thank you, commissioners. Yes, Commissioner Harris.
Hi, thank you. That was very clear and responsive and easy to follow. So thank you for that. Could you talk about the relationship between the initial detention and then the detention recommendation that goes in the report? Right? So there's like, you get a kid that comes in, police tell you he's being booked for murder, so you detain him, and then you're doing a whole bunch of work in the next 48 hours, right, to come up with the detention report. So could you talk about what your understanding is of the law and the 707Bs, and what requires a detention, and then what your analysis is for, and any laws that bind you or don't, or policies that bind you or don't, for the recommendation that you then make to the court in that initial detention report?
Yeah. So a lot of the legwork was done throughout the year, is when we revised the detention criteria. So a lot of things have happened prior to me coming on board. The IDC was, for the most part, trying to release 707Bs. It was brought to us by one of the judicial officers that we were breaking the law. Basically, you're not abiding to this law. So one of the welfare and institution codes that really, when we talk about 707Bs, is the 625.3 WIC. That was one of the statutes that was brought up, is basically saying that you are not to release the youth prior to the youth seeing the judicial officer. So that was pretty much what the statute criteria falls under. So even though a youth may be detained on a 707B, that doesn't mean that we can't recommend a release on CDP. It doesn't mean that we can't recommend a release without CDP based on the mitigating circumstances. So again, when we talk about the risk assessment, we're training our officers to make sure that they're making an appropriate recommendation. Yes, we're detaining the youth at intake, which means we have to make an automatic decision to detain the youth based on the charge, but we can still make an appropriate recommendation based on the risk assessment. So, and that the quality assurance, the review of the cases, the review of the LAT scores, the review of pretty much everything, including the parent statement, all that comes in alignment to make sure that the report is very, is within policy, that it's objective, and that it's following some type of pattern. And, you know, we're trying to keep the officers to make sure that they try to maintain within the criteria, and also that the recommendation is falling within an alignment. When we talk about court detention, basically there's very few charges that fall under that, and those are like bench warrants. You'll have a CDP detain on first, and pretty much those are the only two court-driven detentions. And unfortunately, a lot of a good number of our detentions are a result of either a bench warrant or a CDP violation. I did have a conversation with the presiding judge, and we were trying to see like why are some of the judicial officers recommending detain on first, ordering, actually not recommending, but ordering a detain on first. Basically what the judge stated is that a lot of these cases, again, there's a lot of complexities going on throughout the cases where the judges are basically at the final step before actually ordering the youth detained. And so that makes sense. You know, they're hearing some of these cases. Some of these kids, youth might not be detained, but they're actually violating their conditions of probation while they're being supervised in the community. And based on, you know, the violation of the probation conditions, as well as, you know, the safety of the youth or the safety of the community, the judges have made that decision to detain on first. So we are, you know, I'm open to discussions with further discussions with the judicial officers to make sure that, hey, you know what, if there's any other opportunities to see what we can do to try to minimize detention, then we will proceed with that. But ultimately, those are the two bulk of our detentions, which is the ones that fall under the 707Bs, the ones that fall under a warrant, a bench warrant order, and also a CDP violation. If you look at the data that we are providing, that compiles about 95% of the detentions at the detention hearing. But again, it doesn't mean that we cannot recommend release at the detention hearing. So yeah, we are detaining those youth at the intake, but again, we're trying to do our best to see if we can try to minimize detention at the detention hearing.
Thank you. Commissioners, any more questions? Commissioner Kakani.
Sorry, just as it relates to the LADs that you're now, the LAD score that you're now sharing with the court and the, you know, defense attorneys, prosecution, everybody, are you just including the final score, or are you including the like whole breakdown of?
We are just including the final score. You know, that was pretty much what we agreed to. And so part of the training was to basically allow everybody to see how that score is generated. But yeah, that's what we're including in the report.
Sorry. Is there, I mean, wouldn't it be beneficial to include the entire document where you're determining that, you know, someone gets a point for being a boy?
Part of the reason is that the LAT score is generated during the generation of the report. It would be very difficult to pull a snapshot of that particular report from the actual report. So it's actually embedded in when the officer is actually writing the report. So I feel, and I believe my executive team feel that just giving the risk score should be sufficient to the public defenders, to the district attorneys and the judges, that, you know, this is the risk. This is the risk score. If it falls under this criteria, it would be categorized as low, medium, or high risk. So, yeah. So it's just the score that's being.
Yeah, I think that's unfortunate, just because, I mean, there's specific segments within the detention screener that certainly raise questions for me. You know, whether a young person, I think it is like seeks approval or gets approval for pro-criminal behavior or something like that. And that feels like it's such a subjective determination. And if I were defense counsel, I would want to know how the probation department assigned a number related to that category. So I don't know, in the interest of like transparency, and if you all are committed to like this whole quality assurance part, it feels like there should be a check related to how each of those kind of individual pieces within the detention screener are assessed. But I guess
thank
that's
you
for a
that.
different
I
day.
mean, I can bring that up and see how, you know, what we can do. But at this point, that's
we're just
and it took a
sharing the
lot of work
score.
to try to get that score in there. So, but yeah, you know, part of it is also training the stakeholders and letting them know, like, this is what this youth is a low risk, medium, or high risk. I mean, I think that was sufficient. That is sufficient to let the stakeholders know this youth is technically a low risk. But to add to that, I just mentioned that sometimes regardless of what the youth is scoring, there's certain aggravating factors that might require a recommendation to continue detention. So
yeah. And then just another question related to overrides. I see that you've provided the number of overrides, being 12, for example, in April. Right. Do you know how many requests were made for an override? Like, is that 12 out of 12? Is that?
Yeah, so I provided you the policy for the overrides.
Yeah.
So any charge that doesn't fall within that policy is technically an override. So, which means a supervisor needs to make sure they approve that detention. So I did, break it down.
No, I understand the reasoning behind when an override is requested. I just wanted to know how many times an override was granted, which you have here as 12, versus how many times it was denied.
I don't have that.
Okay, that's fine.
Basically, you know, these are only the youth that were detained.
Right, got it.
Because some of those could be field side outs. Remember, we are also tracking youth that are being recommended for side out. For example, if there's a case like a 422 misdemeanor battery, and our officers are talking to the law enforcement agency over the phone, they're going to divert the youth over the phone. They're not going to bring the youth to juvenile hall unless it's more to the point. You know, I mentioned those 6 questions that we're trying to assess.
Yeah.
If they fall under, you know, if the resources are depleted, then yes, bring the youth in. That would be considered an override. But if, you know, what you're asking is basically those could be field side outs. So to do an in-depth analysis is be very, you know, I mean, we are tracking all the field side outs. We're recording the names, the charges, and all that. But, you know, it is, you know, that's pretty much what you're asking. So the ones that would be denied would be a field side recommendation to the officer.
Okay. And then I was just looking at the reasons for detention, I guess, that don't require SDPO approval, or it says without SDPO approval. One of the bullets is undocumented youth without verifiable address, without parent or guardian, and any youth with a LAD score of 12 or higher.
Right.
Are those like independent clauses, or is that because there's the and in there, it's not an or? So I was just curious, is that like one youth who's undocumented,
right,
and does not have a parent or guardian and has a LAD score of 12 or higher, or
right,
are those like, does that make sense what I'm asking?
So, you know, the policy is very old. It's dated. We usually don't use those, some of those override reasons. We majorly use safety to the victim, safety to the community. There's a certain number of overrides, but those are listed because that's the way our system was created years ago. You got to understand that the system was created when probation used to detain all sorts of youth. You know, we used to have low to medium risk youth that were being detained back in the days. We're no longer doing that. We're basically trying to divert those youth away. So some of those override reasonings that are embedded in our policy and also in our system, we know are not using those. So if I was to go through our IDC stats that we've been providing you, you will not see some of those override reasonings in our data that we're sending you.
I think that this is a section that does not require an override. Section 802.
Okay.
That's what I'm reading it as. SDPO approval is not required. So I just was trying to, that third bullet has 3 different segments, and I'm just trying to understand if they all apply to just the undocumented youth population, or.
Oh, I see the third bullet. Are we looking at the reasons for detention or?
Reasons for detention without SDPO approval.
Okay.
So I'm assuming those are the.
Again, yeah. Undocumented youth. Oh, yeah. So again, this is a policy is dated. We're in the process of revising the policy.
Okay.
So yeah. Again, you would not see that as an override reason. So.
Okay. But I'm reading this as this whole section does not require an override.
Right.
So I get that, as I'm just trying to understand that third bullet when it says undocumented youth without verifiable address, without parent or guardian. Is that applying to the undocumented youth part of the sentence? Or is that just any young person without a parent or guardian?
Yeah. So this is, So this is, again, we would not basically detain a youth for this reason. If a youth is detained and there is some type of crime and brought to juvenile hall, we're going to basically assess, what's going on at home. So, for example, if we have a youth that's a runaway, or we have a youth that's on a warrant status, and we're unable to determine where the youth resides, based on us unable to verify the address or get a hold of a parent or guardian, and there is like a legitimate criminal bench warrant, we would have to detain the youth. But as far as undocumented youth without verifiable, I can't really answer to the undocumentation part,
right?
Because we are definitely looking at, is there a safe place to release the youth? So if a youth is brought to juvenile hall, period, for any reason, it's because youth was already assessed prior. And if there's a situation where the law enforcement agency says, hey, we're holding a youth for a criminal charge or a bench warrant, if the youth does not have a residence or home address and it does not merit a mandated detention, we're going to defer them to DCFS. We're going to say, hey, call DCFS because we can't, it's not a detainable charge. So the next option would be get a hold of DCFS to see if they can find the youth's parents, or maybe they might be in the custody of a guardian. But if it's actually like a criminal charge, the youth will come to us, and then at that point we will basically make that decision to detain. And if we can't verify the address, or we can't get a hold of a parent, then we will do 2 things. We will we can utilize DCFS, or if the charge is egregious, then we will detain the youth. So I'm hoping that answers your question. It's just you really caught me off.
I mean, this is your policy, not mine. So I'm just trying to make sense of how both the public would read it and presumably a probation officer who's being
is pretty dated. So
trained on this.
And I agree with you 100% that some of this needs to be looked at again. So
okay. So this 801 reasons for detention document, this whole thing is being updated?
That's what you're, excuse me?
Is this whole document, it's 801 and 802, is this whole document, because there's no effective date on this document that we received. And so I'm just curious, when was it effective from, or is this pending? Is this?
It was approved by the prior deputy director, and it is in place. I will have to find out why there is no effective date on that.
Okay. So it's out. Okay, just stop because I'm
I'll
not really
follow
getting anywhere here.
with that.
And then I had one other, just related to the warrants number, right? I guess in April, 48 young people were detained on warrants. And then in March, it was 41. So that's a pretty substantial number of young people who are being detained on warrants. And just so I understand, these are young people who already had their arraignments, were out, on like supervision or at home, and then they violated those conditions. And then I'm just trying to understand like who this population is.
So you're looking at the bench warrant
Yeah, it's just
numbers.
the warrants. Yeah.
So when a youth fails to go to court, the judge will obviously the judge will issue a bench warrant. So some of these cases could be youth who are on community supervision. Some of them could be who are in a suitable placement who run away from a group home. Or it could be a youth who actually escapes from an actual juvenile facility, which is very, very rare. But when there's an actual bench warrant, we have to detain the youth. So just bear with me. Hopefully, Are you asking why there was a reduction or why there was?
I mean, it's just such a high number, 41 and 48. So I was just curious, like, are these young people who then end up staying in LP for an extended period of time, or is this like a short stay population?
So a warrant is treated just like an open charge. So we're still trying to assess. And I'm going to give you an example. There was two cases where you guys were asking where we recommended release without CDP in April. One of them was a bench warrant. And basically, after discussing the case with the mother, it was a medium risk youth, and our officer discussed the case with the mother. The youth got angry the day of the court, refused to go to court, and the warrant was only 2 days active. So the judge issued a warrant. 2 days later, he got picked up. After discussing the case with the mother said that the youth is compliant at home. He's attending school. It's not so, does have some negative peers. But our officer, went against the mitigating factors, used the mitigating factors and went against the LAT score, which is what I'm trying to say on a positive note, and recommended release without CDP, which is a good thing, because based on the mother says, I have complete control of the youth. He will show up to court, I'm going to show up to court because he was already detained. But ultimately, the judge decided to release him back on CDP. So that, so the youth, so again, these bench warrants doesn't mean that they're going to be detained for a long period of time. We are trying to do our best to, again, it's not only a detention report, but we're also addressing the warrant reports. It's a warrant report, and we're also making a recommendation whether to detain or release.
Okay.
Using the same, objective guidelines.
Got it. Okay. I think, sorry, just one relate to the LAD. I know you're updating the LADs. I don't know if you wanted to speak more about what that process entails. I mean, I know this was part of the DOJ settlement from 2021, and it's been an issue that has been pending for some time and has been listed as a non-compliant part of the settlement for some time. So just, I don't know if either one of you can speak to what that update process is looking like.
I don't want, I brought Tom here to help talk about the revised LAD. Well, we're going to call it a risk assessment because it is a completely new risk assessment. And I think it's important for us to lay the foundation of what's coming up in about a year from now. Again, I did mention earlier that that his team has developed a risk assessment that's currently being validated. And based on the conversations and the meetings that we had, and again, this is not just the probation only. It's a collaboration with the Department of Justice as well. So we've been meeting, on a monthly basis or bi-monthly basis to see what the progress is, and they've been doing a lot of work in this. So I'm really proud of Tom and his team of what they've done so far. And I don't know, Tom, do you want to just add a little bit about what you guys have done with what you guys have done?
Yeah, is there anything specifically, Commissioner, that you'd like to know about it?
I mean, what is the lot of work? I don't know, that's just like, it's all vague terms, and we've kind of been living in this world of vague for a while. So just if there's any concrete things, like things that you are updating or specific things within the detention screener that currently exists that you are taking a closer look at, or additional, factors that you are considering. We don't know what we don't know. So if you could provide some context, any context really would be helpful.
Okay, I'll try to answer kind of briefly so that you can kind of ask the follow-up questions in the right direction for me, okay? Because I ramble. So we did a validation of the LADs back in like 2022, 2023, And we saw that it was about in line with the other juvenile risk assessments out there in terms of how well it performs. There's something called the area under the curve. You might have heard of that, but basically you can think of it as kind of a percentage. It's not really, but you can think of it that way. And it was about 65. So 65% of the time you could say it's right. It's not exactly what it means, but if you want me to recite the exact definition, I can. And so we thought, okay, well, if that's pretty much how the other risk assessments are doing, we could argue we're kind of in the ballpark of what everybody else is doing. But if you think about it, we're talking about taking away somebody's freedom. 65% is a lousy number. And so even though it's the standard, you're not going to find a for sale risk assessment out there for youth that actually does better. There's a couple Canadian samples that say, hey, look at our number. It's really high. It's 70. But then when you try to replicate it in the United States, you can't. So 65 is about where it is. So we just kind of decided to junk everything. As you pointed out already, the lads had some subjective items. The chief wasn't happy with those. You pointed out you get a point just for being a male. Disparate treatment based on immutable characteristic. I think there's a law about that. So we just threw everything out and decided to just recreate, if we were going to do a best practice risk score in 2025, which was last year when we started it, 2024 maybe is when we started it in earnest, before it was another team working on it. How would we do it? And so we just thought, okay, we're going to take some, what we know about machine learning. We're going to take the case data we have in PCMS, so it's about 110,000 youth, and we're going to look at all the tables. Sorry, PCMS is our case management system. It's about 450 tables on the back end. Some of it is not used, but a lot of it is. And so we can take data out there for all of these youth, and we know what happened with them because we have followed up for many years. We can even look at their adult data if we wanted to. So we just built everything we thought we could, and then just followed basic steps of machine learning to identify, they call them features, because we're not trying to explain the variable, we're trying to predict it. So we're not trying to say, we think that every one of these factors is a cause of the youth's behavior. We're stepping away from that language. We're just thinking of it as, can we predict it or not? Can we predict that the youth is going to not show up at court? Can we predict that the youth is going to reoffend once they're back in the community? That's all we're doing. So running through all of the methodology can be done if you're interested. I mean, there's a report we provided to the DOJ, so that means it's floating out there somewhere, so we should be able to share it with you without anybody having a concern. Now we can predict using that, we call it a retrospective validation, 0.9. 0.89 something for predicting recidivism. So it's worlds better than anything out there. The board could probably bottle it and sell it if they wanted, because other people could use something a lot better. The prediction, we made a second score, which is prediction to failure to appear, because we thought that the judges would be interested in knowing not just is the youth going to reoffend, but also is it possible the youth's not going to show up, because that might be another reason they want to detain. And so that risk score also is about 0.9. So that's based on retrospective analysis, 110,000 youth. The last step is, well, does it work going forward in time? You can ask a weatherman, what was the weather a year ago? And they'll tell you, or an economist, when was the last depression? But you ask them to predict the future, they don't do as well. People are very proud of fancy models, and they don't always do what they're supposed to. So we built the model with the historical data. Now we're kind of applying it on the back end. Caesar's been really gracious about making sure that all of his team's work is moving into an application that builds and feeds into a database. No more spreadsheets, because it's 2026. And so he's allowing us to kind of build this in on the back end. And so for the next year or so, we've got a dashboard that we'll be able to share with you soon if you're interested, I assume. And Caesar will be able to talk about it at length. And it's going to show, as the data trickle in, how is this risk score doing in terms of prediction now? And once sufficient data has kind of been accrued, that everyone who's a stakeholder feels reasonably comfortable with moving forward and says, okay, the tool actually does what we think it does as well as we think it does. Then the plan is to transition over to it. It's not going to require the officers to make a lot of judgments. The data's already in the system for anybody that's had any engagement with law enforcement or probation before. As soon as their name and their PDJ number are typed in by Caesar's team, it'll be there already because it's already been calculated that morning. We have a morning run. Every morning, the data is going to rerun and recreate the risk assessments for anybody that's in our system. So the only time that we would have to worry about not having one of these already in system, ready to be evaluated and looked at, is for the new arrests, somebody who's never been arrested before. And we're figuring that out because, again, thankfully, Director Meyer-Keen's putting all of that data into a database, and so it's going to be a lot easier for us to leverage that.
Commissioner Jackson was been waiting, and then Commissioner Terry.
Yeah, thank you. Mr. Arcos, you offered an example of, it was a positive example of how a parent's input into the assessment basically led to the youth being released a bit ago. Is that right?
I'm sorry, was the
Yeah, it's to you.
Oh.
Oh. What did I say?
Arcos.
I apologize.
That would be nice.
I apologize. I apologize. Yeah, but you provided an example earlier. Is that right?
Of the
Of a youth whose parent, his mom,
Yes.
offered some
Yes.
feedback that ultimately led to the youth being released.
Yes.
I want to know the degree to which a parent's input, feedback sort of contributes to the outcome, or like how it's assessed or
So-
how it's factored into the assessment,
So
basically.
part of my training and the quality of, to enhance our reports is our officers are being trained or have been trained actually to talk to, our officers have been instructed and trained to ask certain questions for the parents. And one of them is basically trying to address some of those last questions, because, and this is something I brought up many times, and Tom just brought it up, that a lot of these youth don't talk because a lot of them invoke their rights, and based on the instructions of their public defenders, they don't discuss what's going on at home as far as like negative peers, any type of substance abuse. So the current LADS is not a perfect risk assessment. So we do try to reach out to other sources, which means we actually are looking into PCMS to see any historical information. We are asking the parents certain questions that would help us get an appropriate risk assessment. Now, it's not coming from the youth themselves, but unfortunately, we have no other option but to reach out to the parent and ask them, how is the youth doing at home? Is the youth compliant? Can you, with the youth, actually, we even asked the youth, would you be willing to take the youth back on CDP? And so we're asking all sorts of questions as part of the interview with the parents. And that should, moving forward, should be included in the state parent statement. So like in the court reports, when a judge reads a report, they're going to see, okay, they've been trained and they know some of these questions that are subjective. They're going to try to, the goal is to make sure that our officers are including that in their reports. Based on the mother statement, the youth does this, B, C. So that kind of provides, the public defenders and the district attorneys an idea, okay, well, that's why the youth scored, that's why this is a score, in other words. So they're not going to get a printout of the actual risk assessment itself, but the goal is to enhance the reports to make sure that that's being addressed in the court reports. So that's and that again, that's how we're trying to address that.
So if there was an example of like a youth who had like a misdemeanor charge, right, and their parent said, listen, my kid's causing a lot of problems at home, I can't control them, I'm really frustrated, and they recommend that you detain the youth. Is that a likely outcome? Is there a subpopulation of young people with circumstances like that?
There are parents who basically say, I don't want my youth. Obviously, we have to write what the parent is stating. We have to articulate that in the report. However, if the parent's saying that my youth is, my son or daughter is doing A, B, C, and it's all negative, and the youth, opted not to talk to us, not to discuss anything about their, their dynamics at home, what's going on at home, are you going to school, then we have no choice but to get that information from the parent. There's no other option. Again, we're also pulling information from other systems like PCMS, but also there's ProBlight where we pull information from DCFS if it's a youth who's actually like under a dual supervision case. So, we're just trying to grab as much information and try to, try to present a factual report and a thorough report to the court. Now, that everything kind of ties in because I mentioned that sometimes some new facts are being presented to the judge. The mom might say, "Hey, my son's doing well," and then in court, "Well, I don't want him. He's been doing this, but that information wasn't provided to the probation officer during the time of the detention report. So that's why there's other new underlying factors that we're not aware of, and that I'm not saying it is a reason, but it may be a reason why some of the youth are being detained, even though we recommended release on CDP, or vice versa. The parent might say, "My youth is doing bad." At the time of the detention report, so we're recommending continued detention based on what we're getting from the parent. But at court, the parent might say, "Oh, my son is doing better. I want him back. I want him a CDP," but that may not have been communicated with the probation officer at the time of the detention report. So again, because it is a detention report, we are only making a decision not a decision, I'm sorry, a recommendation whether to detain or release based on what we have in front of us. And again, time is limited, so we're trying to do as much as possible to make that appropriate recommendation.
Thank you for that.
We are short on time and they need this room afterwards. Is there any more final questions from the commissioners so that we can move on to public comment? Okay. Okay. All right, Wendy.
Thank you. We'll move on to public comment. And before we do so, I want to say last month I made a comment in my remarks about my hopes and expectations for presentations from the department, including providing data in advance and coming and providing robust presentations that were explained in a way that helps the commission to move forward. And I would just like to say that this is precisely what I was asking for. So thank you for the way that this information was presented. And we received this data, gosh, it was like 2 weeks ago, if not more. So it gave the staff a chance to evaluate it. It gave the commissioners a chance to view it and ask better questions. So I think I just want to really appreciate the way that you came today. I don't see anybody lined up at the podium. Oh, I do. You're just farther back than I expected. Please, please proceed with your public comment.
Good afternoon. My name is Kelly O'Brien. I am head deputy of the Public Defender's Office Youth Services Division South. And first of all, I want to thank you for the presentation in regard to the LADs that you did provide to our office. So we appreciate that. But to be honest, the scores itself are useless without the assessment behind it. So there is no effective way for us to be able to cross-examine this information, to give the court any additional information to find out what was missing on this report or give any meaningful assessment to it. So for instance, when you talked about school performance being a factor, there's no way for us to tell what points you gave to school performance, whether or not you were aware that the child is or should have had an IEP that they weren't given, that although attendance has been negative, it has significantly improved over time, or that grades have improved even if they are somewhat low. So there's no way for us to tell how many points you gave on that. And then you talked about mitigating factors. Well, there's no way for us to tell if you've already assess those mitigating factors and given negative points for those mitigating factors already or not. And so if there's information that we have, we can verify, we can provide to the court that will change that score. The court has no way of knowing what you've already assessed and used and what you haven't. And the courts do rely very heavily, sometimes too heavily, on probation's assessment without us being able to effectively use that information in order to challenge it in court. So I wanted to be honest about that, and also concerned about the new risk assessments that you are creating to make sure that the complicated issues in regard to accuracy with social biases and other factors are being considered.
Thanks for being here, Kelly.
Thank you.
Appreciate that. Welcome.
Good morning. Excuse me. My name is John Roque, Deputy Probation Officer, 38 years. I'm also a Local 685 Vice President. I just wanted to bring up a point about our community supervision. We keep putting the bells and whistles on the juvenile, but we forget that there's supervision on the adult. And it's woefully lacking, not only to the community, but to the victims. And let me give you an example. So I had an individual, one of my colleagues tell me that they're a San Gabriel Valley office, 2 people only, 2. And they have to supervise 800. You also have to remember within that 800, there's sex offenders, domestic violence, and we don't have any enhanced case management. You have to have case management. Remember, the probation officer is an unadversarial agency. You have the courts, you have the policing, but the probation officer tries to integrate the probationer, whether it be the youth or the adult. And then the other, I also had another comment from my colleague on our East San Fernando Valley office. Again, woefully cannot supervise adults. There's no supervision because all your supervision officers are in the halls. All of them in the halls, including myself. You got infirm. Imagine having somebody 55, 60, 65 in the halls trying to do the use. And we've already had some comments here. Almost 60% have some mental disability. But I think just to bring up, majority of them are socially dysfunctional. Imagine trying to put somebody in a box, 16 youths, gang members. And then the other thing I just want to show, if you were the no call, no show, you can imagine why that works. Because we're emotionally fatigued. Imagine being exposed to that every day. And I think the other misrepresentation, you woefully have statistics not about the assaults on probation officers.
Thank you. We are asking that you stick to the agenda item, the
Thank you.
topic of the data with the, yes.
Good morning, Deputy Probation Officer Goldner, Los Petrinos, and Stewart for Local 685. Good morning, Director Mayor King. Based on the data that you provided, if we filter out all the low-risk offenders, by definition, the remaining general pop will be HROs, high-risk offenders. So what effects will that have on the institutions? Thank you.
Can you repeat that again? What effect is?
Yeah, so if we filter out all the low-risk offenders, and now by definition, right, we're going to have high-risk offenders remaining in the halls or in the institutions generally. What effect is that going to have? Or would you agree with that assessment that we're going to have remaining high-risk offenders?
Well, I mean, to basically divert the youth that are low to to medium risk and get them out, divert them from juvenile hall, you have a lower population. That's the bottom line. So we're trying to get a lower population to create a more safer environment for both the youth and the officers in juvenile hall. I'm hoping I'm answering your question, Goldner. Now, Goldner was one of my.
Maybe the statistician can answer just by the numbers, right? The remaining population is going to be high-risk offenders. Would you agree with that, sir?
Yes.
Thank you. Kevin?
All right, thank you. So first, when I read the agenda, I see that there's some sort of effort about the reduction of population of the probation department. That's a little bit concerning to me because the way I understand is that it seems like you want to set up yourself as a quota system. I don't know what's the reason behind it. So it seems like if 1,000, 2,000 people committed crime right there, and somehow you are trying to reduce the number that you accept, that seems like doesn't make any sense because according to the latest LAPD commissioner meetings in the LAPD, so basically the residents are saying that how is that even possible that we feel there are more criminal like a looter, rioter on the street, but the LAPD arresting data are saying that you are making less arrest. That's a little bit contradictory of the statement of community safety. Second of all is that when you are trying to reduce the number of whatever, and then you are using a risk score, I believe that's what I heard. I mean, I'm not a big fan of a risk score, some sort of assessment of using a score. If the assessment of a risk score is very, very accurate, well, every one of us can just put 1 year salary into the stock market and using a risk score, and after 5 years, everybody retire as a millionaire. Well, the reason why we don't do that is because we don't believe certain thing as a risk score. What happens if people who that you are saying that, okay, that's a low risk, we release them, and then within 5 years, they rape a woman, they kill a woman, they will whatever sort of murder several people, are the commissioner will be held responsible because you guys made a policy of reducing the population. You guys the one who decide to have a policy that we do not put them in custody. Are you guys will be held responsible for that? That's my concern.
Thank you. And I agree that we didn't talk about that during the presentation, but I will say under the POC item on the agenda, there are some new population statistics graphs that are based on the department's population numbers, not related to IDC, but the basic demographics that our team has put together. And it does show there has been a reduction in the total detained population in the last few months. I was just looking back, and I think I see numbers like 590 a few months ago, and now the number is closer to 570. So it's it's not an insignificant overall reduction, but it's more complicated than just directly related to IDC implementation.
There's a lot of other factors.
But you can see, the members of the public can see that information directly in that report. We have one online commenter, and then we'll wrap up public comment, which is Derek. And Derek, since we weren't able to hear you, I would welcome you to comment on the prior agenda item and this item. If we can hear you this time.
So where is?
Oh, okay. We
can
can
you
hear
hear me
you.
now?
We'll begin your time now. Please proceed.
Okay, great. And no, there's no pussy over here. Please don't disrespect me. My name is Derek Glassier. I have a few issues with this board. I'm concerned that this oversight board is just overqualified to help individuals who are on probation, who are being terrorized by this director, who are being racially profiled and terrorized by their this board doesn't that is on that are all the probationers that are on probation, court order probation. Maybe one or two of you are, but for the most part, this director is completely out of touch with this population. I've heard you all say a variety of things. You talked about things. You've insulted me multiple times. I'm college educated. I've been to 3 or 4 different universities, have 3 or 4 different degrees, 3 degrees exactly, and just graduated in December of 2025. So I think you have me confused with someone else. But you all need to get it together. This board needs to be more reflective of the probationer population as opposed to all of these academics who've never been in the criminal justice system, never had any interactions with law enforcement. And it's just a complete fabrication of what you all were put in place to do. You're an oversight commission, but you don't have any hands-on experience with the probationers or the probation population. Some of you, I would say those maybe 1 or 2 do, but you don't. So you're out of touch. So that's why when a guy like me approaches you, you have all these labels and all this fear and all these anxieties because you don't want to deal with the people who are actually on probation who have to adhere to and suffer by some of the decisions that you make. We need a body that's more reflective of the probationer population as opposed to people who are just read a textbook, got to sit on a mission. The government watchdog.
Thank you. I think that's the end of public comment. So we can move on. Thank you very much.
Okay, thank you, panelists. Commissioners, any final questions before our panelists step down? Yes, Commissioner Shipp?
Yeah, and maybe this does reflect it, right? But once a new, every so few months, maybe few years, there is a new depopulation plan. Does this policy change with those plans? Is this policy put on hold? How does probation go about these kinds of policies? Or do they have any type of emergency planning where policies change just for the temporary time being? Or is this something that stays in place? Like if the chief today said, we need to get the population down even more, would this policy still be in place? Would that change for IDC, or would it be on pause? Like, what would that look like?
So when I talk about the change in policies and any revisions, it's basically to look at long term, and basically the ultimate goal is to reduce population, and based on what the policy is currently, based on what our IDC's goals are, based on the law, based on court orders. If you were to review our current policy, a lot of it is based on low to medium risk detentions. The language is basically saying, hey, you know what, if the LADS works, when there's a low to medium risk. A lot of this stuff is really dated. If you look at the history of the risk assessment, it was introduced in 2009, almost 20 years ago. Okay, so some of the language in the policy that reflects the LADS, it doesn't mirror or doesn't match what's happening in today's date. So when I talk about changing policy, is basically saying it's more for higher risk, more for medium to high risk, and say, okay, we're already doing efforts to divert. Maybe that needs to be put in the policy, and I think there is a section in there that does talk about that. But there's certain language that needs to be changed, and I agree. I'm working with our policy unit to do that. It's a slow process, but there's so many things going on right now that it is going to happen. But for an emergency depopulation plan, that would have to come from our executive team. It's not part of our IDC policy. It's not going to be part of the IDC policy.
I just wanted to make two comments about the data that kind of relates to some of the public comment around, all of the young people inside of LP are, unfortunately that public commenter just left, but are the most serious or violent offenders. But of the 175 intakes that were processed on new youth detained in juvenile hall, only 70 were 707Bs. So yeah, that everyone in there is this like high risk, violent person feels like a little bit of a flawed statement. And then the other issue related to, I guess it's assaults on staff. And while this isn't, I guess, the whole world of assaults on staff, we used to get some physical, what was it? I can't remember. There was some more use of force or like some more like physical incident data, but even just looking at the OC spray data from May 18th through, what is it, June 14th maybe, there was no OC spray deployment for assault on staff. So that feels like a positive move.
Could I just ask if we could, with regularity, or at least some more time, get Tom, I don't know, is that, to come back and maybe show us the dashboard, kind of explain this. I'm curious if like AI is helping. This feels like a very sort of non-probation, like, I don't know. I mean, we always hear about how difficult data is, and then you're sort of saying, it's all there and we can do this great thing and this state-of-the-art thing and have a 0.89%. I just would like a little more time with you, not today, but I think coming back to see the dashboard, see what you're building, explaining it in a little bit more depth would be incredibly helpful, especially as you're taking input and you're in this year period of figuring this out.
Thank you. Great suggestion, Commissioner Harrison. One thing I've seen when we start asking for the data, we just find that it's never ending when it comes to data, right? It just leads to more questions. Thank you very much for your time. And that is it, commissioners? Okay, thank you. Thank you, panelists, and have a good day.
Thank you very much.
We look forward to coming back with more data.
Okay. You're welcome.
So now we will move on to agenda item number 5. We will discuss and take possible action on probation's new visitation policy and continue progress in implementing best practices in visitation procedures, presented by Staff Assistant Veronica Castillo. Thank you very much, Ms. Castillo, for your patience. After hearing the report, the POC will vote on a motion to dissolve the POC's Policy Ad Hoc Committee, which we are doing because of the accomplishments you are about to hear about, and because it is our practice to limit ad hoc committees' work to approximately 1 year. At a future meeting, we may consider creating a new ad hoc committee to review some other policies we are interested in. Attached to the agenda are reference documents on this topic from previous POC meetings. Ms. Castillo, the floor is yours. Thank you very much.
Thank you. Good afternoon, Chair Canales and Commissioners. Thank you for the opportunity to provide an update on the Los Angeles County Probation Department's visitation policy. My name is Veronica Castillo. I'm the Special Assistant to Chief Deputy Robert Arcos. The department's visitation policy has been finalized and approved by the chief and is currently being reviewed by the union. We look forward to sharing the policy once final approval is received. To improve access to visitation information, the department has implemented an automated telephone line that provides general visitation information. The telephone line it lists the telephone numbers for all probation facilities and offers callers the option to connect directly to a facility. The telephone number is 562-392-7254. Absolutely. Area code 562-392-7254. And it's being promoted across the department's online platforms and posted at all facilities. To further support family visitation, the department continues to provide disposable pants, jackets, sleeves, and bandages to visitors who do not meet the department's dress code requirements, allowing them the opportunity to participate in visitation. In support of the new policy, staff continue to receive training that emphasizes visitation as a rehabilitative practice that can reduce tension within facilities, improve youth behavior, strengthen family engagements, and support successful reentry outcomes. The department recognizes that family is not separate from rehabilitation. It's central to it. We remain committed to strengthening family connections in ways that reflect community values and our shared commitment to a passionate, effective, and rehabilitative probation system. According to OYCR, there are currently 12 of California's 58 counties that permit contact visits. As previously shared, the department's policy is grounded in the opportunities in the principle and importance of family unification and permits opportunities for contact visits, which consist of a brief hug at the beginning and at the end of a visit. The department authorized contact visits during Mother's Day and Father's Day weekend. Positive feedback was received from youth, families, and staff. Moving forward, contact visits will continue to be authorized on designated weekends. The department is sincerely grateful for the collaboration, guidance, and support provided by the department's ad hoc visitation committee, OYCR's co-Lancaster, Mark Varela, Annie Selch, and Alicia Hartz, and Executive Director Wendy Julian, Dr. Sarah Gongora, and Commissioner Shipp. Your valuable input and partnership have been instrumental in helping the department make meaningful progress. Thank you for your time. I'm happy to answer any questions.
Commissioners?
Can I just provide one update that the department did provide a draft of the policy for feedback to the committee months ago. There were conversations back and forth, which the committee was able to provide feedback on, and also provided a link to the dress code document. And we have a link on the agenda for the policy. We're like days away, I think, from the availability to share it. It just was bad timing because of the expiration of the time that the union is able to comment on it. But we will make sure we leave that link active on the agenda. So once we have the policy, we'll upload it so the public can also review the completed policy. People will be able to see it when it's ready. Did I say that all fairly?
Yes, absolutely.
Thank you. Yes, Commissioner Harris.
Castillo, could you just share the department's commitment to continued implementation, feedback, keeping this conversation alive so that it's not just a policy that disappears into policies and it's, there's fragmentation across the different facilities and just how the department is planning to keep this information available, fresh, current, and clear to, new parents, new guardians, and what you're doing as far as implementation.
Absolutely. So I've personally been visiting the facilities during visitation. I've spoken to parents directly, and I've spoken to youth to ensure that they know that the services, we want to ensure that they connect with their families. So we're open to working with them, and we're trying to promote this throughout the department and online. Yes.
I think I heard you say that there were contact visits that were permitted on Mother's Day and Father's Day, and that there were positive reports from obviously families and staff. So what is the plan for continuing that?
Well, we just want to ensure that we have enough staff available to supervise appropriately. We're open to contact visits, it's only our staffing. So we try to plan ahead in order to accommodate those.
Can I, if I could as well, one of the questions that I asked, and I think the committee asked in reviewing the policy, was about the approval of those visits at some of the other facilities, like the East Camps, for example. And they explained that there is a way for the chief to provide a pre-approval of contact visits that gives the local administrator of the facility the ability to do it more frequently. It's just easier at some of the camps than it is at the larger facilities, of course, precisely because of the staffing. So there does seem to be some flexibility in the way that the policy allows for those contact visits.
Yes.
I guess, is there you made the plans for Mother's Day, you've made the plans for Father's Day, so is there something that can be implemented so that this happens with some regularity, especially at a place like LP, where I think young folks are probably the most vulnerable, really not knowing what the future holds for them, and that connection and that contact actually feels more important at a place like LP. I mean, not that it's not important everywhere, but I think when young people are experiencing that much uncertainty, feels like contact with family feels really important. So just wondering if you can speak to a desire to do this more regularly, or a plan.
The department would love to offer contact visits for every visit. Unfortunately, we're not able to, but that's the plan that we're working toward.
Once a month, or is there no specificity right now?
I don't know. It would be the chiefs.
Okay. Yeah. And then just the last question was around denials of visits related to canine alerts, and that there is a 1 week kind of suspension. I was just wondering if you have any sort of, I think this, when Mr. Arcos was here some time ago, we had talked about what is the appeals process? Is there an appeals process, or is it just a mandatory 1 week, kind of you can't come back because you've been alerted by the canine for any number of things, right? It could be cannabis, which is actually legal in the state of California. It could be, you didn't have to, you could have used cannabis the day before. No one's saying that it's being brought on you. I was just responding to Mr. Meredith's comment that cannabis or such substances are not allowed on the facility, but that's not what the canine is necessarily alerting someone to. It's just the smell. So I was just wondering if there's any sort of additional steps that someone can take if they've made a trek from a super far place to come see their child. And if they've been alerted by the canine, is there any sort of appeals process or immediate kind of, action that can be taken by the department? Or is the plan just to be a 1 week suspension?
The current plan is if a visitor is alerted, they're turned away that day, but they're free to come back the following visiting day. The youth is notified, and we offer a video call for the youth and parent to connect.
Yes, Commissioner Terry, and then Commissioner Meredith.
I think it was already answered. I had a similar question about future contact visits, maybe for holidays like Thanksgiving or things like that, but it sounds like maybe we can put this on a future agenda to get an update on. So,
Commissioner Meredith. Yes, Commissioner Meredith.
Yeah, I know we've used the reserve probation officers in the past on visitation, and they kind of become what I'll say extra eyes there. Are we still using them?
I'm sorry, repeat the question?
We have been using the reserve deputy probation officers as extra eyes on visitation days to help out. Are they still using them?
I don't know.
Because that would also help accommodate some of the visitation.
I don't know. I can't answer that question.
Can you look into it and then you could email Wendy? and she-
Absolutely.
Okay,
Yes.
great. Thank you. So follow up. Commissioners, any more questions? Well, thank you so much, Ms. Castillo. We really appreciate your presentation and the efforts towards making changes and hopefully getting more contact visits in place. Thank you. And I have been on, oh yeah, public comment. So sorry. Oh, that's right. Okay. Yeah, so Wendy, I'll go ahead and turn it over to you.
I think we need a motion to dissolve the policy ad hoc committee if you're still interested in that.
So we have a motion to dissolve the committee. Oh, we'd like to make it. Would anybody like to make a motion?
I'll make the motion.
Thank you, Commissioner Shipp.
I'll second the motion.
Seconded by Commissioner Kakani.
Okay, so we'll go to public comment, both about this item on visitation and the motion to dissolve the visitation policy ad hoc. Rochelle, you can begin.
Thank you very much. So I want to present you with some more facts today. We represent a 15-year-old youth who's currently detained at Barry J. Nydorf. That 15-year-old youth was denied visits from his family, in-person visits, I want to be very specific, for two reasons that resulted in him not receiving any family contact in person for weeks and months. First, his grandmother was denied a visit because an alleged warrant existed. That came up when she went to go visit him. We had a hearing on this matter where Superintendent Martinez came into court and testified that there was no system that allowed for warrant checks. In fact, he stated that the VAX system was the only system that probation had access to, and that VAX system does not have access to warrant information. We have to this day not been provided the actual alleged warrant that exists, and in fact, our information is that no alleged warrant exists. In addition, what we were told on the record is that because no system exists, that probation at Barry J. Nydorf is not conducting background checks on family members who visit. We have, in fact, opposite information where family members are being asked to fill out paperwork about background checks, and those background checks are being run for some reason through some system. What system is being utilized to conduct background checks on family members who are visiting at Barry J. Nydorf? What information and what databases are being contacted? What information, private information about youth and their families are being shared with databases? Do those databases include federal information? This is information that would be very important to provide to the public, especially vulnerable family members who would come and visit their loved ones. In addition, I echo Commissioner Kakani's concerns about the canine checks. Thank you.
Thank you so much for that. And I would request an immediate follow-up to some of that information she's seeking, because it's very relevant to how we're trying to move forward in a positive and productive way, but yet there seems to be some kind of, contradictions there. Thank you. Hi, Kevin. Go ahead.
Hey, good morning. Long time no see. How are you? So two comments. The number one is that I wish that during the visitation or whatever, you guys can provide some sort of a internet access or maybe a weekly internet computer entertainment hours or something, but based on what I know, it seems like they just have a TV and then a fixed number amount of video games. They just never have access to news, media, and then whatever. So I do believe that we should learn from Holland. We should learn from Germany when their prison system that it feels like a luxury hotel. I don't know why they were able to sustain that kind of model. I don't know why that you are actually walk out of your prison, and as long as you go back before 5 p.m. to sleep in your prison, that's considered as okay. I don't know why they were able to do it, but for you guys, providing a computer is considered not possible. But something we can learn from Europe. Second is that it seems like during the visitation policy, during the visitation period, there's very little limited privacy. It seems like you are visiting in a public hallway, like something like this. What happens if one of your people right there, they want to have sex? What happens if they want some like intimate moment with their loved one, with their girlfriend, boyfriend, because Black Lives Matter said sex is a human right. You should not deny them that right. And then I was concerned of the safety of our probation officer, because if someone who were denied of having sex, my concern is that they're gonna eventually rape a probation staff member. They're gonna eventually assault a probation staff member. So I just want to making sure we can learn from Europe, allowing them like a weekly sex time or whatever for 5 hours, let them have sex. So something that should make them feel better.
Okay, do we have any online commenters? No. Okay, so that's.
All right, no public, no online comments. So now,
Can I ask a
commissioners.
question? I'm sorry. Can we get follow-up, or were we going to get follow-up on the, you had asked? Yeah.
Yeah, I did request follow-up, and you are going on Rochelle's questions
Yeah.
and concerns? Yes, absolutely. And Wendy said she would make sure to get it.
Oh, okay. I didn't know if that was now. Okay. It's later.
Okay.
Okay.
Okay, is there any further comments or questions? Yes, Commissioner Ship?
I mean, I'll just say it real quickly, for everybody too. Like last time we talked about this, like I said, this is just the tip of the spear for us. Like I think, this is for everybody on this commission. Visitation is a huge thing, and so this is something that we will continue to work on, continue to monitor. And so just the dissolving of this ad hoc is just because of time limits, but the work is still going to happen as well.
And we can reestablish the ad hoc should we see that things are not moving forward in the way that we had hoped. I mean, a 15-year-old without being able to see any family, I mean, that is a serious concern, and and how many others. But I have seen some changes. I've been at LP where family members are not being turned away because of their tattoos and things like that, and seeing some shifts there and being able to experience that has also been good. And hopefully we could just get more of those contact visits and things in order. So now.
Okay, so I'll be calling the roll for a vote to dissolve the committee. And I'd just like to say thank you to Commissioner Ship and all the commissioners who served on this committee for your work. So please vote yes, no, or abstain to dissolve the policy committee. Commissioner Harris? Yes. Commissioner Jackson? Yes. Commissioner Kokani? Commissioner Meredith? Yes. Commissioner Prater is absent. Commissioner Ship? Commissioner Terry? And Chair Canales. So with one absence, the vote is unanimous to dissolve the committee. And I just want to say thank you very much to Ms. Castillo. This work went forward without a board motion, it was a very collaborative effort between the committee and the department. So it's been a pleasure to work with you all on this, and I appreciate the shout out in your comments, and I look forward to the continued conversation about this.
And I'd also like to make one more final comment. I was recently with the family, and the siblings are very, very close, as you can imagine. Most siblings are. And probation actually recommended that that it would benefit the youth to see their siblings and to keep that bond going, and the judge denied it. So, there's also times where probation does put forth that effort in trying to keep that family unification, and then it goes back to the judges, so it's like the whole bounce back and forth. So we do appreciate those efforts when probation makes them, understanding the importance of family, the family bond. Keep that. Thank you. Thank you so much.
Thank you.
So now we will move on for agenda item 6. We are going to discuss and take possible action on a report by Executive Director Wendy Julian. This report will include updates on outstanding and current requests for information, and analysis of probation's data, and possibly new requests for information, which we will be voting to approve. Wendy, the floor is yours.
Thank you. And I know we're running out of time, so I'm going to try to be quick on what is a very important issue here. So as many of you know, at the last Probation Oversight Commission, the commission voted to direct OIG, the Office of Inspector General, to subpoena some information. And I have an update to provide on that, which is there were basically, I'm going to say 4 items, but it was sort of 4 categories of items that were requested, and 3 of those have been resolved. One, which was the data snapshots, were provided in their entirety, actually sort of immediately after the meeting. The second was related to the presentation today, to some of the LA Detention Screener Score information, intake data, which was provided almost in its entirety, and the department offered to have a meeting with us to discuss the information that's not yet been provided, and explain some of the challenges around providing it, some of my misunderstandings about how the department collects some of that data, and the challenges in providing it the way it was requested. And the commissioners felt very much like that conversation was held in good faith, and that they can continue to receive the information in collaboration with the department. The third item was related to some outstanding budget questions. I had a conversation with Deputy Chief Williams and then with Stacy Lopez Maddox, the administrative chief, who was able to explain again why some of the data is difficult to obtain, and then also provide a significant amount of the data. And I think you'll hear more from Commissioner Harris in a moment about another plan going forward that answers that question. The one final item of information that was not provided to the commission is the 8-module course around the gender responsive course, the gender responsive training and the consultants work at Campus Kilpatrick. That information was provided confidentially to OIG, but in discussion with the commissioners who made the motion around the subpoena, which is Commissioners Kakani and Harris and Chair Canales, they were not satisfied with the information being provided confidentially. So, I mean, you can speak for yourselves on that, but that's the progress on the information. I will say, there weren't a lot of information requests in addition to that from the prior meeting, so I don't have anything further to report on outstanding information requests. And I think, as you heard today, we actually have had some really valuable conversations about a lot of those other topics with probation staff and leadership, like director level leadership, to be able to understand some of the information better. So I really hope that continues. I think, I mean, I don't think there's anything to act on at this point, unless you have questions about the receipt or non-receipt of that information. It's not something we have, as you all know, talked about, because we're at the public meeting now, so you can talk about it now at the public meeting. But that's the end of my report in regards to the receipt for information. So I'll pause and then move on to the next.
Commissioner Brooke, Commissioner Harris.
Commissioner Harris is going to give an update on the budget committee, which I'll turn this over to her in a second. But anybody else have any comments on that? Okay. Okay, great. Attached to the agenda, you will see a very, I think, now I have to be careful about this, great report on the call out and staffing absentee data that was created by the POC Data and Research Team. That's my bias. I'm thankful to the probation department for providing information that allows for us to do analysis. I think that the data and research team are doing a really great job of presenting information in a way that is more consumable and useful by the commission and the public. So there is a lot of information that's available there. I also wanted to highlight that there are some OC spray reports attached to the agenda that show some very promising reductions in OC spray. I hope to continue to see those. And we actually have a data analysis on some of the OC spray that we will be sharing in the near future. So thank you to my team for all of their amazing work on that. And then we have, what time is it? 12:47. We have the committee reports on the agenda, but I think I'll kind of leave it up to you all about how much or if at all you want to do committee reports, with the exception of Commissioner Harris, who I know has a report and a motion on the agenda. So yes, right. So I think you could just say we don't need to report on it if that's correct, but I'll let Commissioner Harris begin first with the budget ad hoc.
Thanks. The budget ad hoc does have a motion, it's rather lengthy. I understand it'll be posted later. Oh, it's posted. Terrific. Thank you, Janae. We are requesting that at our September 10th meeting, and we're doing this in advance because Ms. Lopez Maddox requested advance notice of getting here in person, that Ms. Stacy Lopez Maddox and Chief Vera Rosa or Deputy Chief Williams provide a thorough in-person budget presentation at our September 10th meeting. We're really seeking a big picture conversation about the actual versus budget expenditures for fiscal year 25-26. I don't believe this commission has ever had a presentation on that. So really looking at what the department CEO came up with, what was approved for that year, and then what did the department spend the money on? Where were the changes? What were the variances? This goes into, again, a whole lot of, we're trying to be very thoughtful and clear about the information that we're seeking. But we want them to be able to come and answer questions and explain this in layperson's terms about the incredible budget and the expenditure that the department has every year. We want information on vacant positions, facility improvements in 25-26 and how the improvements were funded, a greater explanation of pass-through money and what that looks like, and where the money goes and what they fund, what the dollars fund. We want staffing data, and then finally, we want explanation on the departmental reorganization referenced by Ms. Lopez Maddox at the June meeting, and then a conversation and a realistic assessment of how lives are being improved by the money that's being spent by the probation department. And that is the proposed motion. So can I make the motion? Yep. I'm making a motion that we approve this motion.
I'll also just add, since I was the only one in the conversation with Ms. Lopez Maddox with regard to the compliance with the item subpoenaed, that she expressed a willingness to provide this. And also some of the information that's listed on the motion has already been provided to the commission. And so I don't want to speak for you, but I think part of the point of the motion is to explain what will go into the presentation, not to say that it hasn't been received, because some of the information has been received.
Right, to increase the public conversation about the budget and the actual expenditures, and to heighten the level of all of us in our understanding of the budget and expenditures.
Now we go on to the public comment.
Yeah, I don't know if any of the other committee chairs.
Oh, yes. Commissioner Terry?
I don't know if this needs to be an amendment, but I think it would be very helpful if whatever materials they're going to provide in advance, we could get that more than like a couple days in advance. Is it in there?
I think it's in the last paragraph.
Oh, that would be so helpful. Yeah. Okay, great.
Any more questions or comments about the motion?
Do any of the other committee chairs want to make a presentation before? Did you say no? I didn't notice that.
I'm fine to wait until next month. I think just as it relates to the CVK ad hoc committee and trying to understand the implementation of the chief's vision that all girls and gender expansive youth would be at a single facility so that their needs could be met in a really special way. There are a lot of questions as to how that's happening and if that's happening, and we're continuing to engage in a conversation with staff at CVK to get a better sense of the data, the definitions, and ideally this training that we are now subpoenaing will provide some more clarity as well.
We will go to public comment on my report and on the motion that's attached to the agenda regarding the request for the budget presentation in September. So those of you who wish to give public comment, please approach the podium. Thank you, Kevin. And if you want to make comment online, use the raise your hand function. You can begin.
Yes, thank you. I want to talk about the call out and no call, no show data, which is, I was never presented any data. but I want to just ask a basic common sense question. What's the reason why that you don't want to go to work? Like using our director as an example, I see that you never call out, you never no show, you go to work very happy. Why? It's because you work in a safe environment. Nobody attack you, nobody giving you a problem. You work with professional staff member that allows you to continue to make a difference in the society. You can do that in a safe manner. But with our probation department, probation officer, that work environment is totally different. Constantly getting attacked, constantly getting cursed, constantly getting, I don't know, raped maybe? I don't know. So with that kind of a dangerous environment, and then remember, our probation officer dealing with, you read the data, you heard the data, 60% of those people are on drug, even though it's mental health drug, or maybe some other invisible drug that you never detected them before. So you are working with so many mental health issues, and then after 10, 15 years, you're gonna have mental health issues yourself. So I just really, and then you also have a Commissioner Kakani on a monthly basis talking about, Commissioner, our probation officer did this right, did this wrong, did this wrong, did this wrong, and whatever. Because I'm here for probably 10 times already, and then I heard zero compliments from her, but I heard all of the negative comments about the probation officer from Commissioner Kakani. When you are working in such a negative working environment, I would definitely agree with why certain officers who do not feel confident, who do not feel supported in their work.
Hi, Mr. Pettis. Welcome.
Hi. I found it extremely interesting that we focus on the call-outs. It's very simple. Officers call out because it's unsafe and deplorable conditions. If an officer requests time off, he's consistently met with, your request is denied. Probation leaves no other option for an officer except for a call-out. The elephant in the room is safety. Everyone dances around the subject, but when I look at assaults on minors, assaults on officers, the stats are alarming. Officers get assaulted on a daily basis, and officer's prayers to get through his shift without a physical assault. There are no consequences for the children. The subject matter experts are saying there should be no consequences. These are the same people who had consequences as a child and made them professional and law-abiding of citizens that they are today. I attended a job fair 2 weeks ago in Carson. Very good, great job fair, a lot of vendors, a lot of participation, but probation is not hiring. We have 1,467 budgeted positions, and we're not hiring.
Thank you. And also, Mr. Pettis did submit written public comment that's attached to the agenda for you all to review. Do we have any online commenters? No, we do not. So we can move on. I didn't think we were going to make it, Chair Canales, but. Yes, thank you. So I will call the roll for a vote on the motion that's attached to the agenda regarding the September budget presentation. Back to my list. Thank you. Commissioner Harris? Commissioner Jackson, Commissioner Kakani, Commissioner Meredith,
Yes.
Commissioner Prater is absent, Commissioner Shipp, Commissioner Terry, and Chair Canales. So with one member absent, the motion passes unanimously.
Thank you. And do we need another vote on the training module, or we're just going to move forward, or we don't have to vote on it or anything, right? We are moving forward with requesting the information. Okay.
We voted on it last time. We voted
Okay.
to agree to subpoena it, and that's just part of the process. I don't think we don't need it, my opinion. I'm not county council. I don't think we need another vote at all to move forward with the subpoena.
I don't think so either. I just wanted to make sure.
If this was already voted on at the last meeting, you don't need to conduct a separate motion.
Thank you so much. All right. So now agenda item number 7. Item number 7 is for matters not posted on the agenda to discuss or to place on a future meeting agenda for action. Commissioners, do you have any announcements or items you would like placed on a future agenda? Okay, some follow-up requests, right? No? Okay. With that, we'll go on to agenda item number 8, opportunity for the public to address the Probation Oversight Commission. Agenda item number 8 is an invitation for members of the public to address the commission on items not on the agenda. Wendy, please facilitate public comment for us.
Okay, thank you. You can start, Kevin.
All right, thank you. I want to continue for my previous 2 minutes talking about morale. Talking about boosting the morale of the probation department. The LAPD sent a survey during the pandemic where 89% of the LAPD officers saying that they no longer have the energy to serve. They no longer have the passion to serve, which is when they sign up for the job 20, 30 years ago, they said, that's exactly the reason why they sign up for the job. But right now they are losing it. As a probation department, as a probation officer, I just feel if the leadership, the probation officer, are not recognizing their hard work on a monthly basis, or if our probation officer are focusing on the faults but completely ignore the good things of they do, I just feel that everybody would feel less supported. When they have such negative mentality, I feel that call out, no show, it become automatic. Do you remember the Costco CEO once said, the Costco CEO said, I don't worry about customer service. Why? He said, once I pay my employee good, the customer service quality is automatic. There's nothing to worry about. Now, that's probably the reason why you go to a typical McDonald's, you are not getting so much great services. But when you are going to a Costco or Apple store, your customer service level is a completely different level. They were being supported, they were being paid well, and then obviously, what's the return, what's the result you get? The better service to your customer. But I think if you can follow the I have 8 seconds. What?
Keep going.
I have 8. If you follow the same Costco formula, I'm pretty sure the probation department officer will no longer call out. If you support them and love them.
Thank you, Kevin. Hi, Mr. Bell.
I'll be real quick. One, I agree with what he just said. That was all facts right there, Kevin. 2, I just want to bring up what I brought up last meeting. Just getting an update on what's the plan for the camps and what their future plans is for Page and reopening Page. And you throw on their plans for promotions too. Because I remember last meeting, the lady said, oh, we're offering DPO2 spots, but she didn't add the part that you need a master's degree in a certain subject in order to get that spot. So I want to see if the probation department is trying to go into that way to where you need a BA degree to be a DPO1, and now you need a master's degree to be a DPO2. Is that their plan? And if so, they need to let us know so I can go somewhere else. But yeah, please just those 2, and thank you very much.
breath because I'm going to read this really quickly. The question is not whether probation should exist. It should. There's a subset of youth whose combination risk, violence, instability, trauma, and mental health needs require a level of structure, supervision, accountability, and intervention that cannot always be provided safely in the community. This is not an ideological argument. It's an operational reality observed day by day by probation officers, clinicians, educators, attorneys, and judges who work directly with the youth. The challenge is not whether intervention is necessary. The challenge is determining which youth requires secure intervention, for how long, under what conditions, and with what rehabilitative services. That is where the debate belongs. Most youth do not require confinement. Some clearly do. Public policy must be capable of recognizing the difference. The goal of probation is not punishment for its own sake. The goal is rehabilitation, accountability, treatment, public safety, and the creation of opportunities for youth to successfully return to their communities. Legislators, judges, mental health professionals, probation leaders, and reform advocates all have a responsibility to wrestle with that balance. The line between necessary intervention and unnecessary confinement is difficult to draw, but pretending that all youth can safely be managed without structured supervision ignores the realities faced by the very professionals charged with protecting both youth and the public. If LA County expects probation to continue providing these essential services, it must also invest in the workforce that delivers them. Recruitment, retention, training, and professional development are not luxuries. They are prerequisites for safe facilities, effective rehabilitation, and successful outcomes for youth. A fair contract for Local 685 is not merely an employee issue, it's a public safety issue, a rehabilitation issue, and a youth services issue. The county cannot demand excellence while failing to adequately support the professionals responsible for carrying out its mission. We need to support the professionals, strengthen the system, protect the community. A fair contract for Local 685 means safer youth, safer staff, and a stronger Los Angeles County.
Thank you.
Right
Let's
on
do
the
this.
money. Thank you.
Go ahead, Mr. Pettis. We also do have at least one online speaker that we'll go to after Mr. Pettis.
I just also wanted to say that the field supervision at probation is at an all-time low. We brought our field supervision deputies into the halls, and we don't have anybody supervising the people on the streets, meaning that we're focusing on the 500 to 600, depending on what day it is, incarcerated, but we're neglecting the 20,000 that are in our communities. And I want to see if we can bring that up as far as how we can make a balance, because right now people are not being supervised. They're going in there, they're getting referrals to come back in a month. A lot of things can happen in a month. And we're denying the probation services. If someone comes to our office and they need services, there's not an officer there to provide the documented referral to get those services. The provider can't provide services without the referral from probation. So it's a very tight line that we're running here, but we're not, probationers being denied services, and we don't have anybody in the field to do this. I heard Mr. American earlier talking about the looking at the people, but if you don't have anybody to check ankle bracelet or monitor these people, then they're just out there, just there. And so if we could bring that up on a topic at a later date, I'd appreciate it.
Thank you so much.
Thanks, Mr. Pettis. And we'll go to our online commenter, which is Clara Goldsmith. Clara de Goldsmith.
Hi, good afternoon. Can everyone hear me?
Yes, we can. You can go ahead.
I'm a law clerk for the Youth Justice Education Clinic at Loyola Law School, and I'm speaking on behalf of our legal clinic and the Education Justice Coalition. Dear members of the Probation Oversight Commission, in August 2025, the Education Justice Coalition published a report detailing LA County's decades of systemic failures to educate incarcerated youth, which includes the overwhelming lack of accountability for the poor education that students receive in juvenile detention facilities. In response, Supervisors Mitchell and Hahn co-authored a motion titled Access to Learning, Fighting for the Rights of Incarcerated Youth, the, quote, November 2025 motion. This unanimously passed motion required that LACO implement recommendations from our report and, in collaboration with other county partners, produce 2 important documents and present them directly to the Board of Supervisors. First, LACO must work with a credible academic research institution and produce a written report analyzing suspension rates and chronic absenteeism trends inside the juvenile court schools no later than March 3rd, 2026. Second, LACO must conduct a comprehensive assessment of the school-prison nexus with policy analysis, regional mapping, identification of resource gaps, and actionable recommendations no later than April 7, 2026. Both of these deadlines have long passed, but LACO has failed to comply with either requirement. To date, LACO has not partnered with any credible academic research institution, and no independent research or written report analyzing suspension rates and chronic absenteeism has been produced. We do not raise this to diminish the Commission's role. We raise this because a report back delivered to the wrong body without the mandated independent research does not comply with the motion. Instead of complying with all the recommendations in the motion, LACO has chosen to focus on the implementation of opportunity rooms. When the November 2025 motion was presented, our coalition shared our concerns about the mention of opportunity rooms.
Thank you. Is the caller still on the line?
Yes, I'm still here.
Yes. Can you follow up in an email to Wendy and so that we can make sure to follow up on your call right now and the information that you've provided? I think it's very relevant and important. Thank you for calling in.
Absolutely. Thank you for your time.
Do you have her email?
If you could please provide that, I would greatly appreciate that.
Thank you. Ismail's going to put it in the chat for you. Also, it's online as well as my cell phone number. Anybody can call me. It is, actually. Thank you. Thank you, Clara, for those comments. I appreciate it.
Commissioner Jackson, did you want to say something?
So there seems to have been some official changes that have been made, some reassignments, some staffing things. I haven't seen anything in writing, but I think the commission may be due for an update of some sort so we can really understand where staffing numbers are internally and externally, meaning field services, like what are those offices looking like, and then also those facilities.
Is that in your motion?
It is. But that's like, is that like a September thing though? Even if it's like a soft update, we need a real-time update like on what's happening because it's all sort of.
The motion that you just passed under item 5D asks the department to provide an updated organizational chart and a breakdown of how many items are allocated to each division.
Yeah.
Does that answer it?
Yeah, I just wonder kind of how the outstanding issue, like, are we going to be able to address any real concerns given that that's a September, like all of August, we'll have no sort of conversation about staffing, basically. So even if we just invite someone from probation to our next meeting, for example, to say, hey, please report back on, what's happening with staffing.
It can just for adult or open?
For both, for detention facilities for juveniles and adult services, just if someone, as a sort of appetizer, if you will, to the September request, if they could just issue us an update. Does that seem fair? I think so.
Yeah.
Okay.
Okay, is that it? All right, so agenda item number 9, adjournment of the regular meeting of July 9th, 2026. Thank you all for joining us and sharing your comments. As a quick reminder, be sure to follow us on social media and subscribe to our YouTube channel at LA County POC. To receive reminders about our upcoming meetings, visit our website at poc.lacounty.gov to subscribe to our email list. It is now 1:11. Can I have a motion to adjourn today's meeting? Motion to adjourn by Commissioner Jackson, seconded by Commissioner Harris. Commissioners, please vote with an I vote. Thank you very much for your time. Thank you. Great meeting today. Thank you.